السلام عليكم. Good afternoon, everyone, and welcome to our academic activity for today. So today we have 3 lectures. The first one will be about descending aorta and thoracoabdominal aneurysm, will be presented by Dr. Afnan Al-Malki. And the second is about endovascular therapy of a thoracic aortic disease by Dr. Rami Al-Ghamdi. And we will end up by a special presentation by Dr. Gerard Lowry from Houston, Texas, about mitral valve interventions. So we'll start in 5 minutes. Dr. Afnan, you can prepare your slides. Thank you. Dr. Afnan?
Yes, alaikum.
Assalam wa rahmatullah. You can start, thank you.
Okay. So, good afternoon. Speaking is Afnan Malki, cardiac surgery resident from King Abdullah Medical City, and I'll be presenting the descending thoracoabdominal aneurysm. We'll talk a little bit about a brief introduction and what can be offered as a medical management and surgical management. So the prevalence of thoracic aneurysm has tripled over the past 2 decades to a current estimate of 10.4 cases per 100,000 person a year. The patients with thoracic aortic aneurysm are at a mean age between 60 and 70 years with a 2-to-1 ratio for male predominance. Unlike the ascending thoracic aneurysm, descending aneurysm are often associated with atherosclerosis. So once thoracic aortic aneurysm is at least 1.5 times its normal size, then we can consider it as an aneurysm, and most of it are fusiform, which means the dilatation involves the entire circumference of the aorta. I think we all know this diagram by now. So we have, it's been classified into 4 different types. Type 1, the aneurysm is distal to the left subclavian artery, and then it descends all the way down till it reaches the renal arteries, and that's count for 24% of the cases. If we have the aneurysm distal to the left subclavian artery and ends by the bifurcation of the aorta, that counts for 26% of the cases, and that's type 2. Type 3 begins in the distal thoracic aorta or below the 6th rib, and then it ends by the bifurcation of the aorta, and that's 26% of all the types. And then we have type 4, which is at the level of T12 or the level of the diaphragm, and then it continues all the way down to the bifurcation, and that's 24% of all the cases for thoracic abdominal aneurysm. So what can we offer medically? Antihypertensive medications, beta blockers are used to decrease the force for myocardial contractions. We have angiotensin converting enzymes to reduce the oxidative stress. We can add statins to inhibit the inflammation via suppressing the NADPO enzymes, and then smoking cessations. The indication for repair included aneurysm diameter of 5.5 to 6.5 centimeter, or if we have a growth rate of 1 centimeter per rate, or if the patient is symptomatic with any symptom that can relate to the aneurysm. The exposure for the thoracic aneurysm or the thoracoabdominal aneurysm is almost the same, with an extended posterior lateral thoracotomy to expose the entire length of the aorta. We're going to go through the latissimus dorsi muscle, and minimal portion of the serratus anterior are divided. Before entering the pleural cavity, the lung ventilation is off or terminated. For the thoracoabdominal aneurysm, again, the same, posterior lateral over the 7th, 8th, and 9th intercostal spaces depend on the extent of the aneurysm proximally, and the incision then is advanced into the 9th intercostal space into a curve inferiorly parallel to the midline of the rectus sheath. So you're going to place your patient in a modified right lateral decubitus, having the shoulder rotated to a 60 and 80 degree, and then the hips are rotated to a 30 and 40 degree. At the apex of the lower portion of the musculocutaneous tissue, at the 6th intercostal space is usually entered. That's the case if we have type 1 or type 2 repair. A lower intercostal space is also entered if we have type 3 or type 4 repair. And then the diaphragm is divided either into a radial fashion or a circumferential fashion. The circumferential or the circular fashion is more likely to be used because it carries lower incidence of injuring the phrenic nerve. When we reach the diaphragm at this level or this stage of the operation, the patient temperature is drifted down to 32 and 35 degrees. So basically, this is the positioning of the patient. And then moving on into, you can see here that the latissimus dorsi muscle is divided, and the serratus anterior has to be somewhere around here. And then the diaphragm is excised. From the picture, you cannot tell which way they chose, but you can see that they did the traction sutures away to expose the internal organs. And then you're going to remove the spleen, the left kidney, and the left colon to the other side, exposing the descending thoracic aorta. Next is the choice for the extracorporeal circulation. We have 3 ways to go with. The first way is the left atriofemoral bypass. Cannula is placed in the left atrial appendage, and the other cannula is inserted into the left femoral artery to close the circuit. The exposure of the left femoral artery the same way as we know it prior to the systemic heparinization. The pericardium is then open and exposing of the left atrial appendage with the purse string sutures on. In case if we want to use the inferior pulmonary vein, is better to avoid opening of the pericardium. And prior to the aortic cross clamp, heparinization is given. The other option would be femoral. We're going to use the femoral vein and artery the same way we know it with the aortic dissection has been mentioned before. And I'm going to talk about the left heart bypass. Of course, since we're bypassing only the left side, we're going to have 2 cannulas. We'll name it the inflow and the outflow cannula. So the outflow cannula is placed into the left inferior pulmonary vein, while the inflow cannula is placed into the aorta near the level of the diaphragm. Adding to that, we're going to have 4 other catheters, 2 of them attached to the arterial arm of the left heart bypass, and it is used to subsequently selectively perfuse the visceral arteries. And then the other 2 cannulas are attached to a system to deliver cold crystalloid solution to the renal arteries. So basically, this is our outflow cannula inserted into the left inferior pulmonary vein, and here's the descending thoracic aneurysm. Here is the inflow cannula directly at the descending thoracic aneurysm below the level of the diaphragm. So this is a better view to explain it. This is the inferior pulmonary vein, and then it goes all the way back to the descending thoracic portion. The 4 catheters we mentioned, we have the two arterial cannulas or catheters inserted to the arterial limb of the left heart bypass, and these will be used to perfuse either or both the celiac and the SMA. And then we have the 2 other catheters connected to the cold crystalloid solution, and will be given to the left and the right renal arteries. Next, we're going to place the cross clamp in 2 ways, either distal to the left subclavian artery or in between the left subclavian artery and the left common carotid. In this case, you're going to have to block the left subclavian artery with a bulldog, and proximally, you're going to place your distal aortic clamp to isolate the proximal segment while you dissect and risect this region. The aorta is then opened in a longitudinal and a circumferential manner, keeping in mind that the esophagus is right behind you, so careful should be given when you transect the aorta. Next, the upper intercostal arteries are ligated to achieve a better hemostasis, and that's another modality for spinal perfusion pressure. We'll talk about this later. The choice of the graft, normally Dacron graft is used as it eliminates pre-clotting with this graft or bleeding through the graft. Most commonly, diameter is between 22 to 26 millimeter, and the suture material should be selected, loaded prior to the prior to the cross clamp application. So we're going to use a double arm 3/0 or 4/0 Prolene sutures at each anastomotic region of the aorta. So the proximal anastomosis is completed by using 3/0 or 4/0, as we said, and then it can be reinforced again using interrupted pleated sutures to ensure hemostasis. So here we said the proximal clamping site, and then you can tell that they did add the bulldog to the left subclavian artery, which means the clamping was distal to the I'm sorry, it was in between. So if we blocked the left subclavian artery, it's in between the two arteries, the left subclavian and the common carotid. And then careful should be given when you place your proximal aorta because you have the left recurrent nerve on your way. Next is the intercostal arteries, and you can see here that they have been ligated after opening of the aorta. Next, you're going to take your clamp and then place it into the graft directly, and then remove your bulldog from the left subclavian artery to restore the circulation. And as you dissect or resect more proximally, opening the aorta, you're going to do this in an open fashion way. The balloon catheters at this point are inserted into the visual arteries, the superior mesenteric artery and the celiac artery at a rate of 100 to 200 milliliter per minute. Boluses of 200 to 600 cold crystalloids are intermittently used to perfuse the renal arteries. If you run into an intercostal arteries, then what you're going to do is that you're going to create a patch or an island into your graft and try to anastomose it side-to-side fashion into the Dacron graft. So here's another picture where they added the catheters into the celiac trunk and into the SMA, and then you can see the cold crystalloids added to the renal arteries. Next, to decrease the organ ischemic time, you're going to take your cross clamp and then move it distally after each successful anastomosis. So first, initially, it was here, and then we moved to this part, and we moved it here. The visual arteries can be reimplanted into the graft into various ways. Either you do an island like what we did before, and then into-side anastomosis, or sometimes the graft itself comes with the ends that reimplanted directly into the arteries. So here what they did, they created an island that I would say reimplanting the celiac, the superior mesenteric, and the right renal artery together within this same island, and then the left renal artery is reimplanted separately. It's the same picture. So here they created the defect in the graft and then started anastomosing or attaching it to the aorta through into-side fashion, and then moving your cross clamp as you're done with your anastomosis. Next, after the left renal artery is anastomosed to the opening of the graft, because we did it separately, the cross clamp is then moved distally past this point to help perfusing the visceral vessels, and then the final anastomosis is completed just above the bifurcation of the aorta. For the closure, after all the clamps are removed, heparin is reversed through the prothmin sulfate. Renal, visceral, and peripheral circulation are assessed. The bowel, the spleen, and the liver also assessed for adequate perfusion. If the spleen is experiencing some kind of capsular injury, or if there is hematomas presented, then splenectomy is the option to avoid post-operative bleeding and hypotension. Next, it's very critical to keep the patient in a state balance between hypertension and hypotension to avoid bleeding and avoid paraplegia and paralysis. So keeping your MAP between 80 to 90 millimeter mercury is very crucial in the post-operative care. Things you should avoid while you perform the surgery is avoiding spinal cord ischemia, and that can be achieved with distal aortic perfusion. And cerebrospinal fluid drainage, a catheter will be inserted in L4, L5, and it should be employed to maintain a pressure less than 10 millimeter mercury, both intraoperatively and then 3 days after the surgery, draining at least 10 cc per an hour. We have other adjuncts that would be somatosensory evoked potential and motor evoked potentials, and those are used to help pursuing selective approach for the intercostal revascularization. You may want to avoid visceral ischemia, and that can be achieved, as we said, through subsequent aortic clamping and distal aortic perfusion with retrograde perfusion, direct visceral and renal artery perfusion using the balloon catheters and cold crystalloids into the renal arteries to maintain a renal temperature below 20. Uh, you have to avoid embolization if the aorta seems to be severely diseased, then profound hypothermic circulatory arrest and reconstruction without cross-clamping is considered at this time. You have to avoid diaphragmatic paralysis, and as we mentioned before, the radial division of the diaphragm carries a higher risk of injury of the phrenic nerve. However, the circular or circumferential division carries a lesser incidence for injury to the nerve. Avoid injury to the vagus nerve. As we know, the anatomy of the vagus nerves as it enters the chest cavity, it lies in front of the transverse aortic arch near to the left subclavian artery and the recurrent laryngeal nerve, and it runs parallel to the descending thoracic aorta. Careful should be given when you try to place your cross clamp and when you try to transect the aorta itself. Avoiding injury to the esophagus, as we said, is directed, located directly behind the thoracic aorta. So when you perform the proximal anastomosis or when you do the cross clamp, the aorta has to be lifted up off of the esophagus to prevent any injury or fistulation. So in conclusion, thoracoabdominal aneurysms develop in patients with atherosclerotic disease, chronic aortic dissection, or connective tissue disorder. Approximately 80% of the thoracic aneurysms are atherosclerotic in nature, and they're associated with smoking, hypertension, dyslipidemia, or advanced age. The risk of rupture is rapidly when the aneurysm diameter reaches or exceeds 6 centimeter. The treatment, medical therapy, and reduction of the risk factors such as smoking and hypercholesterolemia, tight blood pressure control. And the intervention that we can offer is either surgical, hybrid, or total endovascular repair. And I think this is the end of my slides. And here are my references. Thank you.
Thank you, Afnan. Any question for Afnan? Okay, so we'll have a 10-minute break and then we'll start with the second lecture. Dr. Rami?
Yes, please.
Yes, you can start. Thank
Can
you.
you share my screen?
No, we cannot.
Just I have an issue with the sharing of screen. 1 second. Can I start?
Yes.
Okay, I am Ram Ghamdi from King Abdullah Medical City. Today, inshallah, I will speak about the endovascular therapy of thoracic aortic disease. So I will go through the common pathology of thoracic aortic disease, indication for TVAR, the role of preoperative imaging and operative steps, complication and goal of treatment, and finally the conclusion. The common pathology of the aortic pathology of the thoracic aortic disease. Firstly, the aortic aneurysm, the enlargement of the aorta to greater than 1.5 times to its normal size. It's been introduced in the previous weeks, so just a quick recap. Regarding the classification of aneurysm in proximal anatomic region, it can be classified as supracoronary, which involvement of ascending aorta only while the aortic root in normal size. Marfanoid type, it will be involvement of aortic root only, and the ascending aorta is normal in size, while the tubular, the involvement of both aortic root and the ascending aorta. The classification, actually, Dr. Afnan, you just mentioned, so I will skip this. The acute aortic syndrome, it's defined or contains the most common three diseases. The aortic dissection is the splitting of layer on aortic wall occurring within the medial layer of the aorta with an evidence of intimal tear allowing the longitudinal propagation of false lumen to be filled with the blood. Intramural hematoma, it's a concentric circumferential collection of thrombus in the aortic wall without transluminal flap typical of the dissection. Penetrating aortic ulcer, localized perforation of the medial layer of the aortic wall beneath an atherosclerotic plaque. The classification of the aortic dissection, we have two systems, DeBakey and Stanford. Stanford type A, it's anything or the dissection which involve of the ascending aorta, while in type B, the dissection which is not involving with the ascending aorta. Aortic transection, it's disruption of the continuity of aortic wall without propagating dissection. The aortic wall is intrinsically normal and resistant to the dissection process. Usually it's traumatic in etiology. So what's the indication for TEVAR for thoracic aortic aneurysm? In asymptomatic patient, thoracic aortic aneurysm, TEVAR is indicated when the maximum diameter of aneurysm exceeds 6 centimeter or if rapid expansion, 1 centimeter per year occurs. Insertion morphologic situation, which are considered prone to rupture, such as sacral aneurysm. TEVAR may be justified at a diameter of less than 6 centimeter. Comorbidity and age of the patient have to be considered, and it may appropriate to set larger aortic diameter threshold in patients with increased operative risk. Regarding the type B aortic dissection, TEVAR is a treatment modality of choice in complicated acute type B aortic dissection. The term complicated means persistence or recurrent pain, uncontrolled hypertension, despite full medication, or early aortic expansion, and any sign of malperfusion or rupture like hemothorax or increasing of periaortic and mediastinal hematoma. Uncomplicated type B aortic dissection, primary is conservative approach with close surveillance seems to be justified until complication arises. The treatment of aneurysm on the basis of chronic type B dissection should be discussed in multidisciplinary team approach, considering TEVAR versus open surgery. In case of penetrating aortic ulcer, the treatment may be recommended when the patient are symptomatic or the ulcer demonstrate expansion and intramural hematoma. In patient with intramural hematoma, intimal lesion laceration can often be found in the inner curvature of the aortic arch. By careful CT angioanalysis, this may be an aim for stent graft implantation in patients with progressive complicated intramural hematoma. In case of traumatic aortic injury, the TEVAR indicated or immediate endovascular treatment is indicated in patients with the complete transection of aortic wall and free bleeding into mediastinum or pseudocoarctation syndrome. Delayed treatment can be suggested when limited disruption of the aorta is present, but the media and the adventitia are intact. So the role of preoperative imaging, the CT and CT angio are essential to plan aortic repair and endovascular technique. It gives accurate assessment of etiology and extent of disease, show the involvement of side branch, adequacy of access vessels, and the presence of extravascular disease that might affect the treatment and selection and approach. The MR angiography, in addition to morphologic information, it provides highly valuable assessment of dynamic flow and filling pattern. It gives information of dissection flap mobility and dynamic obstruction, which may impact the clinical management. This CT showing the type B aortic dissection. We can see here the intimal flap. Also, with the new modern technology, CT angio can be reconstruction, and it's provide 3D imaging, and it's helpful for endograft sizing and access and assessment of the axis. In some cases, cross-sectional CT cannot appreciate the tortuosity of the axis of the vessels, like in iliac or femoral. So to assess the severity of calcified disease prior to the entering the operating room. In case of thoracic aortic aneurysm, sufficient proximal and distal landing zone of at least 2 centimeters is crucial for safe deployment and durable fixation of stent graft. If landing zones are shorter or significantly angulated, prior transposition or bypass surgery, rerouting of involved aortic arch may be considered. In case of thoracic aortic dissection, CT can help to classify the type of disease, localization of all tiers, identifying the primary entry tier. Ishimura zone of implantation. Actually, it's a classification system describes the zone of implantation within the aortic arch based on location of normal aortic segment relative to supra-aortic trunk. So the ideally segment of normal aorta are selected for placement of endograft with minimum of 2 centimeter length of normal parallel aortic wall without excessive thrombus or atherosclerotic debris. We have 4 zones in thoracic aorta. Zone 0 started from ascending aorta to distal innominate artery, while Zone 1 from between innominate and distal left carotid, and Zone 2 between the left carotid and distal to the left subclavian artery. Zone 3 beyond the left subclavian and along the curved portion of distal arch, 2 to 4 centimeter distal to left subclavian. Zone 4 involve the most descending of thoracic aorta. Operative step. Imaging, most of the cases carried on angiosuit, where the modality of intraoperative imaging is a fluoroscope. It's provide digital subtraction and road mapping. The digital subtraction allow removal of background image such as bone structure to enhance visualization and geography, and road mapping involves transfer of reference image superimposed into live image for guidance of deployment during deployment of the device. IVUS is an option for patient with renal insufficiency or patient have contraindication to contrast. It's also promote advantage to direct intraluminal imaging. It can help to identify if, in case of aortic dissection, true lumen versus the false lumen. Regarding the access, we have most of the patient, the femoral artery provide adequate access for them by either cut down or percutaneous. Femoral access can be obtained via transverse incision. It's made at level of inguinal ligament and femoral artery exposed, then sheath placed in the artery, as is seen here. Iliac artery. If the femoral artery is suboptimal for access, the iliac artery may be exposed with the retroperitoneal approach and can be directly accessed if size less optimal. Less than 8 millimeter, the conduit can be an option. A 10 millimeter Dacron graft can be sewn to the iliac artery as conduit for the delivery of the endograft. The conduit may be brought through a separate counter incision in the groin to allow for better angulation of the relatively long and stiff deployment device. Flexible wires introduce retrograde to the aortic arch under the fluoroscopy. And the guide catheter, we have many guide catheter, but most likely they use cordless and multi-purpose. It's advanced to the reach over the flexible guide wire, and then the soft guide wire can be removed, and the stiff guide wire can be advanced through the guide catheter to the level of aortic arch under fluoroscopy, and catheter can be removed. Stiff guide wire to leave the stiff guide wire in the position for deployment of endograft. Angulation and tortuosity of aortic arch might cause difficulty to deliver endograft with flexible guide wire. And that's why we use the stiff wire. But we never introduced the stiff wire to arch without guide catheter because of risk of rupture and dissection. Then the thoracic endograft device introduced over the stiff wire after preparation of the device have done. Special consideration, TEVAR for thoracic aortic aneurysm. Detailed attention has to be paid to the length of landing zone, sufficient overlapping if more than one endograft is being used, and angulation in the aorta. The stent graft should exceed the diameter of landing zone by at least 10 to 15% of reference aortic diameter. Under fluoroscopic guidance, the endograft is delivered to the proximal landing zone, and the optimal image to arch and brachiocephalic C-arm placed in LAO of 45 degree. Then diagnostic arteriogram is obtained to confirm the location and position of the endograft. Rod mapping may be used to facilitate precise deployment of endograft. If second endograft planned for deployment, the adequate overlap is necessary to prevent junctional or type 3 endoleak. Ballooning of landing zone as well as the junction between endograft is device specific. So we can see in this picture, after introduction to the stent graft and assuring with the arteriogram imaging, the deployment of a stent graft done. In case of thoracic aortic dissection, the treatment goal is the occlusion of primary entry tear, and the size of the selected stent graft should be based on the diameter of the aorta, proximal to the dissecting segment. Here we don't do no oversizing. So most of the time, the entry tear of type B aortic dissection located close to the origin of left subclavian artery. Technical challenge, especially in complicated type B aortic dissection, is the access to the narrow true lumen. Confirmation of wire access in the true lumen is mandatory before deployment of device and may be aided by use of AVIS. Ballooning is not recommended after deployment of the stent, as retrograde dissection and rupture being reported. And this picture illustrates the type B aortic dissection. And the second picture after the stent graft deployment. Also, this is the other picture for type B aortic dissection. And here we can see the picture after the stent deployment have done. Sometimes the additional re-entry site and fenestration are present in the distal aorta. Treatment with bare metal stent or uncovered stent may be necessary if important branches such as renal, visceral, or lower extremity artery continue to be malperfused after the proximal therapy with TEVAR. Patient with the history of CABG, lima to LAD, or with subsequent neurovascular compromise associated with the acute coverage of left subclavian artery, a concomitant left subclavian carotid artery bypass should be performed. The completion of angiogram is performed to examine for endograft migration and endoleak. If endoleak is detected, treatment such as ballooning or placement of additional graft stent should be performed. If all satisfactory, delivery system is withdrawn from the access vessels, the stiff wire is left in place of any event of vascular injury or avulsion occurred. By retaining wire access, an occlusive balloon can be advanced over wire to achieve the proximal control if necessary. Once the surgeon is confident there is no vascular injury, the guide wire is removed and the repair to the vessels done. So, definition of treatment of success. In case of thoracic aortic aneurysm, technical success is achieved when the endograft is deployed accurately and the aneurysm is excluded from the circulation with the absence of type 1 or type 3 endoleak. We will speak about the types of endoleak now in the next slide. Follow-up of patient demonstrating complete thrombosis and shrinkage of the aneurysmal sac and in the absence of complication. Thoracic aortic dissection, the technical success defined as closure of the primary entry tear, absence of type 1A endoleak, and the induction of false lumen thrombosis. The aim of endovascular treatment to resolve complication of aortic dissection, including malperfusion, bleeding, and imminent rupture. Hybrid arch procedure. It's a combined open cerebral debranching with concomitant antegrade endovascular stent placement. Benefits of the procedure, it's limit the duration of cross-clamp time and the cerebral ischemia. In last decade was performed more as the treatment option for aortic arch aneurysm in elderly people with high comorbidity incidence. The key concept of this approach is debranch of the cerebral vessels, reconstruct the ascending aorta to create a healthy landing zone, and deployment of antegrade stent graft from zone 0 to healthy distal aorta, which lead to exclude the arch aneurysm. The classification of hybrid arch repair based on location of aortic aneurysm. Type 1 hybrid arch. In type 1 hybrid arch, there is the sociable non-aneurysmal proximal aortic zone 0 and distal zone 2-3 landing zone for a stent graft. In type 1 hybrid arch, there is we will perform debranching procedure is performed by to bypass the cerebral vessels and involve an end-to-side anastomosis for 4 branch graft to ascending aorta. After that, the endovascular stent graft is deployed antegrade via separate side branch of the graft with the distal zone in native ascending aorta at zone 0 under the fluoroscopic guidance. In type 2, here we don't have suitable landing zone, proximally in zone 0, but suitable landing zone in 2 and 3. There will be a presence of ascending aortic pathology, which require replacement of ascending aorta and debranching of cerebral vessels. So the stent graft can be deployed to exclude the arch aneurysm. After that, the multi-branch tube graft is used to replace the ascending aorta and cerebral vessels are bypassed. Stent graft deployed antegrade via separate side branch and landed distally in zone 0 within the graft. Type 3 hybrid arch, diffuse proximal and distal aortic aneurysmal disease, which require replacement of ascending aorta and debranching of cerebral vessels. And distal anastomosis completed in aneurysmal aorta, but will be excluded after stent graft is deployed. Stent graft is deployed antegrade via side branch in the graft where the proximal landing zone will be in distal aorta. Chimney technique, it's a complete endovascular approach to exclude arch aneurysm. It's a staged procedure. Initially, the left subclavian artery to carotid artery transposition and left carotid artery to innominate artery bypass. After several days, the stent graft is deployed retrograde through femoral access and landed proximally in zone 0 or 1 with fenestration at innominate artery. The right axillary then can be accessed to deploy a retrograde stent to the innominate fenestration. And here the picture show the Gemini technique in this system. Selection is critical in case of Gemini technique. Selection is critical, and this approach are for patient at too high risk for the open procedure. Disadvantage, stroke and type 1 endoleak, need for secondary intervention, and conversion to open repair is still high. Complication of TEVAR. We have endoleaks, retrograde aortic dissection, which occur in acute type B aortic dissection repair. We can have bleeding or rupture from the access site, a stroke due to excessive manipulation within the arch, or inadvertent overstenting of one or more the great vessels, spinal ischemia, and contrast-induced nephropathy. In this picture, we can see the retrograde type A aortic dissection while repairing the type B dissection. Type of endoleak. Type 1 is persistent filling of the aneurysm sac due to incomplete seal or ineffective seal at the proximal side, this type 1A, or distal side at the end of the stent graft, this is the type 1B. Type 2, persistent filling of the aneurysm sac due to retrograde branch flow from collateral vessels. And type 3, blood flow into the aneurysmal sac due to inadequate or ineffective sealing of overlapping graft, joint, or rupture of the graft fabric. In type 4, blood flow into the aneurysmal sac due to the porosity of the graft fabric, causing the blood to pass through the graft and into aneurysmal sac. While type 5, not commonly seen these days with the modern technology and of endograft type, it's aneurysmal sac expansion without clear evidence of endoleak origin. Type 1 and type 3 endoleak are regarded as treatment failure and require further treatment to prevent continuing risk of rupture, while type 2 endoleak are managed primarily conservative by wait and watch strategy to detect aneurysm expansion or except for supra aortic artery. In this patient, coil embolization, plug occlusion, or surgical ligation should be performed during or early after the TEVAR procedure. Spinal ischemia, it represents the most serious complication in treatment of thoracic aortic disease. It has an incidence of 2 to 6%. The risk factor is long aortic lesion or long aortic coverage more than 20 centimeter, prior aortic surgery, stent placement at level of T9 to T12, where is the origin of Adam-Quiz artery, which provide the major blood supply to anterior spinal artery. Coverage of left subclavian artery, preoperative hypertension, occlusion of iliac artery, and the duration of procedure time. Prevention of spinal ischemia can be achieved by targeting MAB above 90 millimeter of mercury, reduce the procedure duration as possible, staged approach in complex endovascular repair, preservation of perfusion to subclavian artery as possible, drainage of cerebrospinal fluid, neurophysiological monitoring during the procedure. Reversal of paraplegia can be achieved by immediate initiation of cerebrospinal fluid drainage and pharmacological evaluation of blood pressure to achieve MAB above 90 millimeter of mercury. The use of cerebrospinal fluid drainage to minimize the risk of spinal cord injury was pioneered by Larry Hawley at Mayo Clinic in the late 1980. It is currently widely utilized for complex aneurysm involving the risk of paraplegia. Despite the lack of clear prospective data, elective preoperative lumbar CCF drain placement for optimization of spinal cord perfusion play an important role in TEVAR. The spinal drain is opened for 15 minutes every hour with the maximum drainage of 20 per hour, a maximum 150 ml per day. If there is a change in neuromonitoring or neurological examination, CSF pressure is decreased to 5 or even 0, and cerebrospinal fluid pressure is raised to 10 once the neuromonitoring or examination improved. Spinal fluid drainage is continued for 24-hour in patients with extent type 4 thoracoabdominal aortic aneurysm and for 48 to 72 in those with extent type 1, type 3 thoracoabdominal aortic aneurysm. CSF drain is removed in patient who had stable hemodynamic and neurological examination after 6 hours of clamping trial. The contraindication of spinal drain insertion include preoperative anticoagulation, intracranial process such as tumor or bleeding, and infection at the insertion site. Follow-up, CT angiogram performed before discharge the patient and 1 year later in case of good result. More imaging and follow-up may be required when detecting endoleak or if considered about stability of the repair and potential complication. Here we see this CT of a 77 years old male patient with acute type B aortic dissection. We can see the type B aortic dissection here, and this picture 1 year after follow-up, which show the patent stent graft. The conclusion, TIVAR offer a valid treatment option for elderly patients deemed at excessive risk for open surgery, but also for fit patients with sociable anatomy, particularly in patients with traumatic aortic injury and acute complicated type B dissection. TIVAR is considered the treatment of choice. At present time, surgical therapy remains the standard care of acute type A aortic dissection. Uncomplicated type B aortic dissection should continue to be treated with optimal medical management and close surveillance until further study define whether the prophylactic endovascular repair will play a role in these patients or not. Paraplegia remains the main complication to be avoided. Close and frequent monitoring of neurological examination post-operative is crucial. Thank you.
Thank you, Rami. Any question for Rami? So the next session will not start before 3 o'clock. So we need to pause because we finished ahead of time. So we'll meet back at 3 p.m. Dr. Lowry,
Good morning.
good morning.
How are you?
I'm good. So welcome back, everyone, and I would like to welcome Dr. Gerald Lowry, who humbly accepted our invitation for today. So for those who don't know Dr. Lowry, he graduated from University of Sydney in 1969, and then he started his residency program in cardiovascular and thoracic surgery in Sydney as well. And then after a visit from Dr. DeBakey to Australia, he was asked to join his team in Houston, where he did his cardiovascular fellowship in 1975. And since that time, he worked with Dr. DeBakey for more than 20 years. He also helped in establishing the cardiovascular program here in Saudi Arabia, along with the Baylor team led by Dr. DeBakey. So after establishment of King Faisal Hospital in 1975, a team from Baylor was asked to join to establish the cardiovascular program, and they did the first operation on 22nd of May 1978, which was a BDA ligation. So after 3 years of this program, around 1,000 of operation was done, and Dr. Lowry helped along with the team from Baylor. So Dr. Lowry currently is practicing at Houston Methodist in Texas with a special interest in valvular repair and minimally invasive cardiac surgery. He also enriched the literature of cardiac surgery with so many publications and prestigious journals. And he will talk to us today about mitral valve intervention. So without further ado, I would like to welcome you again, Dr. Lowry, and the mic is yours.
Thank you very much, Luai. My wife and I have many fond memories of the 9 months we spent in Saudi Arabia in 1979, 81, and 82. And we've been very proud to see the excellence of the program that's continued through the years, through now almost 3 generations of surgeons. So I appreciate the invitation today to talk about mitral valve repair. And I hope to give you some interest in a somewhat different approach to it than the traditional Carpentier repair. And of course, Carlos Duran, a colleague of Dr. Carpentier, was a prominent figure in the history of your institution also. And you're going to see we have some fundamental differences in our approach to this problem. So I'm going to get my PowerPoint presentation going here. So this is a program we've had at Methodist now for almost 20 years. It's been a major team effort between us and the University of Houston. We've found a lot of interesting things about the mitral valve. Of course, the modern history of mitral valve repair began in 1967 when, by Dr. Carpentier's own account, driving into the Hospital Bruxelles, he looked at the iron gates, the 2 flaps, and the masonry surround of the gates, which he thought about maybe was the mitral annulus, and wondered what would have to be done to fix this after an earthquake. This is his own handwritten drawing here. And he had an insight that was very important, which was not only would you have to resuspend the gates and realign them, you would have to do something to rebuild the annulus so that the gates would open and close correctly. From this, he went ahead and did autopsy studies on 100 patients with various forms of mitral valve disease, and observed that whereas the normal annulus looked like this, the majority of his patients, particularly with degenerative disease, had a very enlarged annulus, especially posteriorly. The leaflets were big, the normals in the brackets and the enlargements in the numbers. And he saw substantial enlargement of the leaflets and elongation of the chordae. From this, again, using autopsy material, he worked out that he felt that the mitral annulus in the middle of systole, when the peak pressure is on the leaflet, should have a ratio of 4:3. This is what he called his golden ratio. And from this, he had rings created, which were designed to fix the mitral annulus in the mid-systolic area with this outline. So he fixed the area and he fixed the shape of the annulus with this rigid ring. He also developed a way of assessing whether that sizing from commissure to commissure and the area of the anterior leaflet would be a sufficient guide. And he worked out that when you pull down on the chordae here, if you have much leaflet sticking out down here below, he called this excessive leaflet height and recommended going up a size on the ring. So he was measuring intercommissural distance, area, and this new term he used of excessive height. I'll just tell you now, we don't believe that there is such a thing as excessive height, and we never measure for it. He treated the flail segments primarily by his quadratic resection, which, as all of you know, has been modified substantially through the years. Most people now are resecting much less, and many people have gone to a triangular resection. And then after the quadratic resection, put on his ring. Now, this was a dramatic breakthrough because at that time, mitral valve repair was extremely difficult to accomplish. There was no systematic approach. He brought out this very systematic and structured method, which is well described in his atlas, which I'm sure you all have. But the problem is that even though we went from essentially 0 to 60% in repairability in the 70s, most people have not been able to get above 60% since then. And worldwide, if you survey all the different countries' databases, repairability rates are widely reported overall in the 50 to 70% rate. People who use the truly classic Carpentier technique have traditionally reported failures of 20 to 30% at the 10-year mark. Even to this date, 50 years after the original description, we see papers in the literature with 5 to 20% of people having some degree of systolic anterior motion. And a continuing and underreported problem is the occurrence of significant mitral stenosis, arising primarily out of the fact that the annuloplasty ring is fixed in the mid-systolic position, even in the middle of diastole. This is our US data from the STS database from 2018, the most recent survey. And you can see that the overall mitral repair rate in the United States is 65%, with 82% for the degenerative and myxomatous valves. So there are very few surgical procedures where we tolerate a 20% inability to accomplish our goal. And that's really what triggered our focus on trying to improve this. This is just an example of one of the most prominent papers from the 2008 timeframe showing this 30% failure at 10 years. There have been a number of papers, and there continue to be papers written about SAM and algorithms to try to avoid it. This is a paper that actually came out just this month in the Annals of Thoracic Surgery from South Korea, showing in a large series of over 1,000 patients, 23% of the people had a 6mm gradient, mitral gradient, post-op, which gradually increased over time. This is up to a 20-year follow-up. And of the people who they felt had non-significant mitral stenosis, the mitral stenosis was actually a mean of 3mm. And there are a number of papers showing that anything above 3mm gradient has long-term consequences in terms of cardiac function and the occurrence of atrial fibrillation. The other thing that's not done widely is testing people for a gradient during exercise. And here we see a study where they look comparing bands and rings, but looking at the big picture, they had a 3 to 4mm gradient at rest in the group with these kind of pulmonary artery pressures, 30, 35mm. And then during exercise, these gradients more than doubled and the pulmonary artery pressure went up substantially. So there is still a big problem out there in terms of mitral valve gradients. And if you're seeing patients going home with 3 to 4 millimeter gradients, this is a predictor of future problems in the long term. So this was our experience. We were inspired totally by Dr. Carpentier. We started out following his techniques totally. There's still a lot to be learned about. He was a great observer of the mitral valve, and his atlas is full of wisdom. It's just how he chose to repair the valves that we have now a lot more data and a lot more concerns. So we started using his technique. As we finally got the hang of it, we got up to about the 80% mark overall, with 85 to 90 for our degenerative patients. But during the 90s, we had a major appraisal using echo and other methods to assess the valves, and stopped using his techniques and went to totally non-resectional techniques using Cordy and flexible complete annuloplasty rings. And after that, our repair rates went up overall to 89%. And for myxomatous and degenerative pathology, we've been achieving 100% repair rate since 2000, when we last did our very last leaflet resection. So what has led us down this path, and how have we managed to improve the results so significantly? Well, Dr. Carpentier obviously was carrying out his work before the availability of clinical echo, and he was relying totally on anatomy and observations intraoperatively and autopsy material. So here's the anatomical mitral valve we're all familiar with: anterior leaflet, posterior leaflet. Anterior leaflet is more or less squared off. Posterior leaflet is a thin ribbon-like structure that's attached to the posterior 2/3 of the left ventricular myocardium, while the attachment anteriorly here is primarily to fibrous structures. The anterior leaflet is very mobile. The posterior leaflet is much less mobile. What we see here, which is commonly thought of as the mitral annulus, is in fact called the mitral ring. The mitral ring is where the wall of the left atrium comes down, comes across the annulus, and is reflected onto the atrial surface of the mitral leaflet. So the mitral annulus is back here, not here. And this is particularly marked anteriorly. So if we look at a cross section of the aorta, the aortic leaflet, the left atrial muscle, and then the continuation of this tissue down into the anterior mitral leaflet, we see that the place we want to be stitching is up here. And if we just stitch where Dr. Carpentier recommended, we've got a significant area of this membrane, which we'll talk about more in a minute, that's immobilized. This again is the ribbon-like posterior leaflet with the chordae and papillary muscles. The papillary muscles are primarily positioned under the commissures. They're not under the leaflets, they're under the commissures. And again, the anterior leaflet here, more squared off. Now the leaflets are maintained in their position by chordae, and the anterior leaflet has marginal chordae, and then it has a small number of very thick, strong intermediate chordae, which are otherwise known as the strut chordae. Posterior leaflet, same marginal chordae. Then they have a number of intermediate chordae, and then a set of basal chordae. And the basal chordae are thought to be primarily related to keeping the relationship constant between the annulus and the base of the papillary muscle. And just looking down up at the undersurface of the mitral valve from the ventral here, you can see the small number of strut chordae attached to the deep surface of the anterior mitral leaflet, and these 3 rows of chordae attached to the posterior mitral leaflet. And from this can give you some idea that the anterior leaflet is going to be a very mobile structure. It has very few chordae holding it from moving, whereas the posterior leaflet has many chordae and is much less mobile. The leaflets come together at 90 degrees. So there's this zone of apposition, which we see on both leaflets, which is a 90-degree portion. And this represents 1/3 of the area of the anterior leaflet and 1/2 of the area of the posterior leaflet. So you can see here on the diagram, 2/3, 1/3, 50-50. The mitral leaflet is attached, the posterior leaflet is attached to the myocardium. the anterior leaflet comes up here. There's an ill-defined transition from the anterior leaflet into a fibrous membrane here, which we call the aortic mitral continuity, which attaches to the left fibrous trigone and the right fibrous trigone, and comes right up to the aortic annulus here. And then there's a triangular area here that's filled in by another little triangle of fibrous tissue called the intervalvar triangle. This area is variable in its length, and this is just how many millimeters long that area of fibrous tissue joining the anterior mitral leaflet to the aorta is. And you can see that the length varies from almost zero, just 1 millimeter here, up to 15 millimeters. Up to 5 to 6 millimeters. So this is a variable in length, and the only way to detect where it is with the tip of a needle. And you'll see this is important to find this fibrous area because that's where we recommend stitching our rings. So basically what we've come to understand is that the D-shaped anterior leaflet of Carpentier is this area here, which is defined not by the mitral annulus so much as by the attachment of the left atrial muscle. So that's the D. And then as we come up again, here's the anterior, the aortic mitral continuity, and there's the intervalvar triangle. So you can see this whole membrane here. When we look at our 3D echoes and look at annular tracking with 3D echo, we don't see a D-shaped mitral leaflet. We see this big area here, which is a combination of anterior mitral leaflet, aortic mitral continuity, and intervalvar triangle. And this all moves and functions as if it was one big anterior leaflet. So when we put things across here that prevent this area from moving, we're reducing the functionality of the left ventricular outflow tract. Here we see a cross section with the aortic valve and its annulus here, the anterior mitral leaflet, posterior mitral leaflet, and the mitral valve and its plane here. So these two valves have a plane that when that meets, it's an angle, and that's called the aortic mitral angle. And this is a very important thing functionally, because an optimally functioning heart during diastole will have blood drain straight down from the atrium and be directed towards the apex of the left ventricle. And then in systole, we want things to come around so that when the heart's ejecting, the blood will be directed straight up into the aorta. And to accomplish this, we excuse me just one second. To accomplish this, we have this aortic mitral angle, and during diastole, this is somewhat flattened. So everything's rotated around to let the atrium drain, and then in systole, it's a little steeper. So usually about 120 degrees in diastole and about 115 degrees in systole. The anterior leaflet here is defined as the anterior wall of the left ventricular outflow tract. This is the definition of the left ventricular outflow tract. The posterior wall here is the anterior mitral leaflet. So the left ventricular outflow tract starts here and ends here at the aortic valve leaflet. So when we're talking about the anterior leaflet being displaced into the outflow tract, that's really not correct. When the anterior leaflet is displaced forward, the left ventricular outflow tract is being displaced forward and being narrowed. And this is the aortic mitral angle, the aortic root, the mitral valve, and it's this big angle here that is the aortic mitral angle. Now, over the years, Dr. Carpentier basically viewed the mitral valve as consisting of its annulus and the chordae and the leaflets. So these are the three components he addressed with his repair. What we now know is that the normal functionality of the mitral valve is highly dependent on the normal function of a group of structures, which has been named the mitral apparatus, which consists of the left atrium, the mitral annulus, the mitral valve leaflets, the chordae, the papillary muscles, the left ventricle. And most important, and what has not been talked about a lot, is the extreme importance of the movements of the aortic root in determining the position of the anterior mitral annulus and the anterior mitral leaflet. This is how the mitral valve should look. This is the anterior mitral leaflet. This is posterior mitral leaflet. And you can see that these two leaflets aren't just flaps drifting into each other. They are actually being propelled into each other by all the different components, the left atrium contracting, making the posterior annulus smaller, the aortic root pushing the anterior leaflet into the posterior leaflet. And notice here again the relatively limited motion of the posterior leaflet. It's more like an airbag. It pops up and sits there in a U shape, and then the anterior leaflet is this very mobile structure being driven into the posterior leaflet. And this is why it's difficult to retrieve a problem with a gap here in a repair by trying to augment the posterior leaflet. So what are the roles of all these different components and dynamic changes? We want laminar flow to occur. That's the most efficient way to move fluid in the circulation. And all these different changes maintain left ventricular filling and ejection by maintaining laminar flow. There's a phenomenon we're going to talk about of diastolic locking, which is the presystolic intense closure of the mitral valve leaflets that prevents the occurrence of early systolic mitral regurgitation. And we know that this can be lost in atrial fibrillation. If you don't have that atrial kick at the end of diastole, then you won't have mitral valve locking and you will have early systolic MR. Now, the leaflets and chordae are very thin and not very strong, but when they're properly aligned and they're properly opposed to each other, strain levels are reduced drastically. And it's very important our repairs leave the operating room with leaflets and chordae in a low strain state for reasons of durability. And obviously the big problem which continues because of lack of proper understanding of many people as to how the left ventricular outflow tract works, of optimizing left ventricular outflow tract dynamics to prevent SAM. Here is the aortic root, and here's the mitral valve, the anterior leaflet in continuity, as we saw with the aortic root. And the first thing to note is that during systole, the aortic root is rocking to a more horizontal position. And it does that, it hinges this edge up so that this indents the anterior portion of the mitral annulus and pushes the anterior leaflet more towards the posterior leaflet. The other thing that's happening here, which is just a little harder to see, is that the aortic root is expanding by about 13% during systole. So the whole root is getting bigger, and then in addition, it is rocking to a more horizontal position. So the combination of this pushes this area upwards and backwards. This brings this into better apposition and also elevates this whole mitral structure up and out of the left ventricular outflow tract. It brings the posterior wall of the left ventricular outflow tract upwards and outwards, widening it. This is reflected in the so-called saddle shape of the mitral annulus in diastole when the aortic root is more vertical and the root is at its smallest dimensions. The anterior portion here is flatter. Then as this area, as the sinuses enlarge, and then rotate, this point rotates up this way, we have the, from the mitral annulus side, we see the mitral annulus coming upwards and backwards, and that's the steepening of the saddle. And then at the same time, the posterior annulus is being brought in by about 25% by the contraction of the left ventricle. Again, you can see the anterior leaflet, this vague transitional area, the aortic mitral continuity, and the intervalvular triangle. Now, this is just a study that was done by Veronese a number of years ago, but it's a very excellent study in that it shows the actual number of millimeters things are moving. And during systole, the aortic root here gets displaced upwards and rotates more horizontally. You can see this rotational motion here as it becomes more horizontal. And this point here, which is in continuity with the anterior leaflet, goes upwards and outwards, and the anterior leaflet goes up with it so that this area is pushed up in this direction by the combination of the expansion and the rotation. And here we see a CT scan study of the aortic root and the mitral annulus. And you can see here during systole, you can see the three sinuses here because the root is more or less horizontal and we're looking at it end on. And this is compressing the anterior portion of the mitral annulus here, making it concave. So this is pushing the anterior leaflet towards the posterior leaflet. And then in diastole, we can see the aorta is more vertical. You can see that you can't see the three commissures, three sinuses as well. And now the aorta is deflated to diastolic pressure. And you can now see that the mitral annulus is at its biggest. And this area here is now convex, making a bigger orifice to avoid this orifice here. You can see it's much bigger than this one. And the posterior wall, posterior part of the annulus is also dilated up because the ventricle is dilated up. So we have a bigger diastolic area and a smaller systolic area. And a significant contributor to this is the behavior of the aortic root. Now we know that the total reduction in area of the mitral annulus during the cardiac cycle is about 25 to 30%. And this is some work we did where we looked at what happens during the cardiac cycle. The mitral annulus is at its largest at mid diastole. And then at end diastole, as we've mentioned, we get this contraction of the left atrium, which brings the area down, brings the leaflets together. We get mitral locking. And then in addition to this reduction in area of the mitral annulus, it moves down about 1.5 centimeters with the papillary muscles as ventricular systole progresses. So we have a translational movement downwards, and then in addition, it's being impinged on by the aortic root. This is just a study that depicts graphically the shape of the annulus in diastole here. You can see the saddle up here anteriorly, that's in diastole. And then we can see the translational motion downwards, that's the 1.5 centimeters. And as it goes downwards, the area gets smaller, that's this gap here. And you can see the saddle shape becoming more pronounced here. So that's just a nice display of the translational motion and the reduction in annular area and the steepening of the saddle. And you can see here what happens when you put a Carpentier ring on. Everything now is at the systolic dimension. The annulus is flattened and the only motion you get is the translational motion of the annulus towards the apex of the heart. So we've lost all these other mechanisms here that help bring the leaflets together and then help them separate in diastole to avoid mitral stenosis. Now, as we mentioned anatomically, we have a zone of coaptation, and this has been studied by echo in detail. And here are just some dimensions as to how much coaptation you get normally. And it varies obviously from the very small dimensions of the P1, A1 area to the maximal areas here of 10 to 12 millimeters you see with the A2, P2 area. So that's a very nice study just showing the development of the zone of coaptation during systole. And this is how the leaflets look coming together. This is the posterior leaflet 50%, 50%, and this is the anterior leaflet coming in 70% and then 30% here. But you can see how the vertical surfaces come together and provide us with our zone of apposition. The zone of apposition increases as systole progresses. Here at the end diastole, early systole, the leaflets are starting to come together. But then as the annulus gets smaller to its 35% reduction in mitral annular area, the zone of apposition increases, and as the annulus is pulled down and the ventricle continues to get smaller, the zone of apposition reaches a maximum. While all this is going on, as we mentioned, normally we have laminar flow. These are just pictures of the mitral annulus here. This is during diastole. We have the blood flowing in, and then as we know, it's basically got to do a 180 here to head out the aorta. That would mean deceleration of the blood and then reacceleration as the heart begins to begins to squeeze, and there'd be this loss of kinetic energy. So the way the blood flows through the human heart is that it maintains laminar flow, and a vortex, a clockwise vortex, develops here in the lower portion of the left ventricle. And this acts as a roundabout. The blood enters this vortex, is carried around, and then is directed up here. In addition, as the blood's coming up here during diastole, there is a smaller vortex spun off that fills the space between the anterior leaflet and the wall of the left ventricle. And this helps maintain separation of the anterior leaflet away from the septum as systole begins, and this helps avoid SAM. So this is an important mechanism in the avoidance of SAM, the presence of this big vortex that spun off the main vortex here, pushing the anterior leaflet away from the septum. And then as we come into systole, we can see the vortex continues, and in early systole, we have the blood being directed up, and then once all the blood in the ventricle is now being directed upwards in this direction with laminar flow, the vortex dissipates. And here you can see spectral tracking of a mitral annulus here, apex here, posterior wall here. And normally the blood's directed down through the mitral annulus because of the aortic mitral angle towards the apex. And as it heads down, we can see the vortex forming here. And then the spin off with this vortex pushing the anterior leaflet away from the septum and the blood being directed up into the aorta. Now, we've mentioned several times that the atrial systole, the contraction of the left atrium here with the P wave, is the point at which the mitral annular area begins to be reduced. And here you can see the beginning of diastole, and the mitral annular area is going up to its maximum in diastasis. And then we've got our P wave, the left atrium begins to contract, and we immediately see a reduction in area, which ends here as systole begins, and then the systolic effects of the left ventricle take over, bringing the maximum reduction in area down to 30%. So we can see the importance of the contraction of the left atrium in the major reduction of the area of the annulus, and this is all diastolic as we head into isovolumic systole. So the big reduction in mitral annular area occurs in diastole. And this is because there are circular muscle fibers in the base of the left atrium, and these contract and actually pull directly on the mitral annulus. And this is the one true cause we can all agree is a cause of so-called atrial mitral regurgitation, the classic one, which is atrial mitral regurgitation due to atrial fibrillation. Now, we've talked about the leaflets being driven together, and basically what we have drawn here is the contour of the left ventricle at the end of diastasis, where we've had passive filling of the ventricle. And then with atrial systole, we've got another 50 to 75 milliliters of blood being injected into this already full ventricle, and that makes the ventricle get a little bigger. And that's this orange part. And it's this orange enlargement of the ventricle here, which gives us the geometry that pushes the leaflets together here, and which pulls the papillary muscles down into a position where we get these leaflets locked together. And this has been a well-described phenomenon. And again, it's very important for normal cardiac function to avoid early systolic mitral regurgitation. And the importance of this to us as we look at repairing the mitral valve is that this sets up, in the normal cardiac cycle, this sets up the leaflets for the progression into systole. So if we can get our leaflets set up in the correct position at the end of diastole, we can be sure they're going to perform very well through systole in terms of their positions. So this is all passive filling except for the squeeze of the left atrium. And so we can simulate this by passively filling the ventricle till it's well filled up. And then we can't directly simulate the atrial systole, but we can fill up the atrium a little more. And importantly, we can pull the posterior annulus forward with stay stitches, and in that way, somewhat simulate the 25% reduction in the area. So just to look at what's happening here, we've now got our annuloplasty ring on, and that's our 25% some reduction in the annular area. And we can now blow this up. And as we blow this up, you'll see the leaflets being pushed together, being rolled in towards each other, flattening. And then as you can see here, we've got even got the steepening of the saddle coming, because the left coronary sinus and the non-coronary sinus here are being inflated, as well as the ventricle, and that's producing our simulation of mitral diastolic locking. And here again, you can see those leaflets coming together, and as this continues, the zone of apposition increases. So once we're set up here at the beginning, we automatically get the normal changes following on. Now, we've mentioned the importance of maintaining good leaflet strain measurements, and we've done a large number of studies, and we've had multiple publications from our group with our cardiology colleagues on mitral strain levels. And this is the normal mitral strain levels, the anterior and posterior leaflets. And you can see there's very little mitral strain except in the region of the commissures in the normally functioning mitral valve. And this is brought about in big part by the development of the zone of apposition. Here we are, late diastole, early systole, very little apposition, coaptation surface area shown here. As systole progresses, the zone of coaptation gets deeper. And finally, we have the full zone of coaptation of 10 to 12 millimeters here. And what you see happening here to stress levels is that as the initial load is coming off the very thin marginal chordae and being transmitted to the stronger intermediate chordae, and then finally being transmitted to the annulus, the stress level on the edges of the leaflets doesn't change much, but the stress is all transmitted out. Finally, when this thing becomes two leaflets essentially blended into one with a drumhead effect, the strain stress levels are almost all transmitted to the mitral annulus. And this is the mechanism why after periods of time with some degree of mitral disease, you get a lot of mitral annular calcification. And this is just a typical insufficient valve with an anterior leaflet malalignment. And you can see this whole area is covered brown as maximum stress. And you can see here, after a successful repair, we've got a reduced mitral annular area, and the anterior leaflet strain levels are back to normal. So this is the goal of our technique. It's the goal of restoration of physiology. Now, these leaflets we're most commonly operating on, of course, I'm sure you see a lot more rheumatic fever than we do in the United States, but still worldwide, degenerative or myxomatous degenerative disease is still a very common form of disease. And just in general, to remember the pathology of myxomatous disease is the rule of two. The mitral valve area is doubled, and the length of the cordia doubled, the size of the leaflets is doubled. And these are very stretchy, floppy structures. The strength of the leaflets is maintained, but you can see the leaflets are shaded and the cordia clear. The leaflet strength is well maintained. The mechanical strength of the leaflets is unchanged, but they are stretchy and they are floppy. On the other hand, the cordae are very much weakened. The big basal cordae don't lose much strength, but the other thinner cordae have significant losses of strength in this pathology. The effects of mitral regurgitation on these big floppy valves is that the mitral annulus becomes flat. So if we look at a normal annulus in diastole, the area is bigger and it is flatter. And then in systole, we have this steepening of the saddle we've been talking about. And then in the myxomatous valve in diastole, we've got a very big area, often double normal. And then in systole, we get a lot less elevation of the anterior part of the leaflet because of the large size of this annulus. And annular dilatation has a lot of really bad consequences. So we obviously don't get leaflet apposition. This big annulus doesn't contract down much. So during the cardiac cycle, we have a lot less reduction in annular area, usually only 15%. These leaflets are very stressed in this condition. And we have even more increase in caudal stress. So it's part of a vicious cycle where once we get annular dilatation occurring, the chordae become stressed and we start seeing caudal elongation and rupture, particularly of the marginal chordae. That's why we're mostly repairing problems at the edge of the leaflets, not in the middle of the leaflets. The strut chordae tend to maintain their function. And of course, the saddle is flattened because the anterior elevation is much less pronounced. The other thing that happens when we get this kind of distortion of the anatomy, when it's repaired by trimming out leaflet and putting on a flat annulus, this is a Carpentier type physiology where we have a flat annulus and smaller leaflets. And you can see the whole structure is severely stressed out. This is a setup, a simulation where we have a three-dimensional annulus with a saddle and the normal larger leaflets. And you can see this as an extremely low stress setup. So this is what we've been able to achieve with our repairs versus this is what's achieved with Carpentier repairs. Now on the issue of SAM, SAM is seen in many diseases of the heart, but the SAM we see with surgery is unique because it is iatrogenic. These people come into the operating room without SAM, and so when they leave the operating room with SAM, we have to classify that as an iatrogenic acquired abnormality. And we're going to talk about the two conflicting theories of what causes SAM, but our opinion is that the SAM we see with mitral repair is due to impaired aortic mitral coupling dynamics, because that means that the anterior mitral leaflet position is in the wrong spot and subjected to the wrong forces, and that's what causes the SAM. This is an example of SAM, which is easy to understand because there's a big lump here from a hypertroph, and we chop the hypertroph off and the SAM goes away. Things are a lot more complex with the SAM we see with the mitral valve repairs. This is work from the Cleveland Clinic many years ago, which is widely accepted by the people who follow the Carpentier teachings. This is the normal thing, and what's illustrated here is a big posterior leaflet. And they feel that when they put their ring on, they pull this posterior leaflet forward, and if the posterior leaflet is too big, this actually pushes the anterior leaflet physically and narrows the left ventricular outflow tract, which in turn leads to SAM because the hemodynamic changes that causes pulling the leaflet even further forward. But if we look closely at a couple of things here, one is that the aortic mitral angle is severely narrowed by use of rigid rings. And instead of being 120 to 130 degrees, more like that, here we now have a 90-degree angle. So the effect of this is that when the atrium empties, it doesn't push the blood towards the apex, it jets the blood straight towards the septum. So there's a hose pushing the anterior leaflet towards the septum when you set things up in this manner. So we don't think the size of the posterior leaflet is the problem, it's the malposition of the posterior leaflet that's the problem. And actually, if you're using a rigid ring and you resect posterior leaflet, you make things even worse because you have to put a smaller ring on here. And that in turn makes the compression of the anterior leaflet worse. And then the other thing is, even though they've drawn this here, this ring attached up here, you'll see that these rings typically actually end up attached down here more where the muscle is reflected off the leaflet. And that's the other important component that's also pushing the leaflet towards the septum. So we think the primary cause of these abnormal effects on the left ventricular outflow tract. Of course, small ventricles, big leaflets, yes. Rigid rings, yes. All of these things are somewhat important, but this is the big thing. If you avoid this, we have shown conclusively in our recent publication that taking care of this part pretty much eliminates SAM. And here again, we've got our anatomical mitral valve. And this is the ring here, and the annulus is up here. This is the intertrigonal fixation line of the rigid Carpentier ring. And you can see that the impact of fixing a rigid structure across here is to prevent this area here, which we've shown normally comes towards us as the blood in the outflow tract, which is directly behind the anterior leaflet here, pushes the outflow tract back into the left atrium in the form of the anterior mitral leaflet. You can see this here attached to the trigones prevents that from happening. And this whole area up here, which normally is available to participate as widened left ventricular outflow tract, is pinned down and can't move up and widen the left ventricular outflow tract. And here we can see some work that was done in the course of trying to develop prosthetic implants for percutaneous mitral valve replacement. But these studies show that if you put a D-shaped ring in the traditional Carpentier method from trigone to trigone, what you're actually doing as far as the left ventricular outflow tract is the left atrium, the mitral annulus, left ventricle, and the aortic root. And so this is the left ventricular outflow tract. You can see here when you do this, what you actually end up here is not that, it's this. And there's the muscle coming down and ending. Here's the attachment point. So we have a fixed, immobile, narrowed inflow, which leads to mitral valve gradients. And then this rigid ring with this 90-degree aortic mitral angle means the anterior leaflet is closer to the septum, and we have a narrowed left ventricular outflow tract, and we're more prone to get SAM from that. Here's another study from Italy done with MRI, same thing. They showed that these rings, which you think are being attached here, are actually being attached here to active mobile tissue. And same thing, you stent the inflow in a stenotic manner, and you make the anterior leaflet's position move more anterior and narrow the left ventricular outflow tract. And a graphic illustration of this is from time to time, you'll get referred to someone who's had their annuloplasty ring put even a little lower than Dr. Carpentier recommends and have severe mitral stenosis, iatrogenic mitral stenosis. Fortunately, these can usually be fixed by simply taking out the old ring and putting the new ring in. Here you can see the rings attached right at the aortic root, and we have a perfectly well-functioning valve with a flexible ring. But the problem here, this whole problem here is caused by ring being sized and attached down here instead of up here. And in the lab, in the animal lab, we can get a preparation, and this is the aortic root here, the left coronary sinus, non-coronary sinus, fibrous triangle, and aortic mitral continuity. We can put a finger down here, and this is just an example of a ring that's been attached from trigone to trigone. And that's my fingertip there trying to displace this ring forward to make the left ventricular outflow tract hollow out by moving this posterior wall towards us. And you can see it's very difficult to do that because this is a rigid band now straight across here. When the ring is attached properly, it's like a bucket handle. And as you push your finger against it, this whole thing rotates up and towards us. And you can see how much wider the left ventricular outflow tract is here. So our goal is to have our rings look like circles when they've been implanted, not like D shape. So that would be the shape of the Carpentier approach, and this is our recommended approach up here. And this line here should be drawn higher up. That's too low. Here again, the effect of putting, we've known this for a long time from putting in prosthetic mitral valves, that then we get this 90-degree angle on the aortic mitral angle, and that this directs blood flow towards the septum. Doesn't matter much with a mechanical prosthetic valve. On the other hand, when we put our annuloplasty ring in and we do this, we're getting our jet going towards the septum, and we have the mitral anterior leaflet here being jetted up against the septum. And here you can see vortex flow studies where we have a mitral repair with a physiological approach, and we've got our inflow being directed against the posterior septum and coming around forming a vortex here and then flowing out in systole. Here with a rigid prosthetic ring or a valve prosthesis, the flow is directed down towards the septum. Here it's being directed towards the posterior wall and to the apex. Here it's being directed towards the septum. Instead of a clockwise vortex, we now get a counterclockwise vortex, which means the blood is having to bounce off the posterior septum and then be directed back towards here, where it's actually still jetting up against the septum. And we don't have our big clockwise vortex here keeping the anterior leaflet away from the septum. We now have a number of forces at work which are making the anterior leaflet go towards the septum, and then ultimately the blood has to find its way out into the left ventricle, around and behind the wall of the septum. So this SAM we see in mitral valve repair is not just a simple matter of a big leaflet being in the wrong position. There are other factors that need to be thought about, particularly the aortic mitral angle and the position of these vortices. So when we come to think about repair, Dr. Carpentier was a magnificent pioneer. He's been a tremendous influence on me. I still learn a lot just reading about his descriptions of various things such as mitral annular calcification. His description of the pathology of mitral annular calcification still is the best that's ever been published. His approach to fixing it, I don't agree with, but his description of these diseases is incredible. So this is his world he lived in. He had autopsy material. He had beating hearts in the operating room, no echo. Now we have the ability to get pictures like this, and we've got 3D echo and very sophisticated analytics. And so the question is, are we going to continue to try to restore normal anatomy and do things based on autopsy material? Or are we going to embrace the huge amount of information we've developed in the last 50 years from 3D echo, CAT scanning, and MRI, and try to enhance our results? And this is the route we've taken. We want our valves to look like this. So this we named the American correction to just give Dr. Carpentier a little nudge with his French correction. And this is based on the dynamic simulation of the position at start of systole of the leaflets. We get to that end diastolic locking position by passive inflation and displacement of the posterior mitral annulus. And we've found that this is a very good predictor of the position of all these important structures that make up the mitral apparatus. We don't think there's any place or any need in these. Since 2000, we haven't measured a single leaflet. We've not termed any leaflet high or normal or too wide. And the whole concept of excessive leaflet size we reject. We have a different concept, which is that big leaflets help get good repairs. In the late 90s, we started doing some robotic mitral repairs, and we did 100 Da Vinci robots, and we had to find some way to do our pressure testing. So we used a suction irrigator from our general surgery colleagues and began using pressurized simulation at 4 liters a minute. And we found this produces a very accurate position. The kind of inflation you get with this is far superior to anything you can do with multiple handheld syringes. And we're basically of the opinion that when you find yourself operating on a 95-year-old with a big floppy mitral valve and big leaflets, clearly there've been many years when he's been living with big leaflets and no MR and had no SAM. And then finally one day he develops MR. If he comes to an operating room at that point and develops SAM, clearly that's something that should be avoidable. We should be able to fix his leak and get him back to where he was, just like before, with no leak and no SAM. And that's really what propelled our efforts intellectually. So the big question is that meets all of us every day, regardless of whatever repair technique we use, and that is how to achieve a dynamic positioning of all these different structures in the right place in an arrested heart. And the foundational principles we've used are that we're going to use a fully flexible, adjustable annuloplasty ring. We're not going to do any leaflet resection. and we very accurately mark the desired zone of apposition with dots. So the whole procedure begins with working out where we want those leaflets to end up. And then the core principle of how we adjust our leaflet position and choose the correct sized annuloplasty ring and make any adjustments we need to the annuloplasty ring is to inflate the heart rapidly at 4 liters a minute with saline up to the mitral locking point where the leaflets are firmly put together and ready to launch into the rest of systole. So all dimensional decisions are made on the inflated heart with no reference to measurements of the leaflets. So like Dr. Carpentier, we believe in carefully looking at the valve and the leaflets. We obviously do a lot of TE in the operating room. And then we have 2 separate functions which are interrelated but have to be done separately. The first is alignment of the edges, and that refers to the height of the leaflets, not whether they've got too much height or too little height. But the leaflets can be either opposite each other or above or below each other. And the first thing we want to do is get them into this plane so they're correct. They may still be over here. They can be like that or that. They may still be over here because the annulus is too big, but we can at least do that. And that's done with the chordae. So the chordae are going to influence our up and down. And then the size of the annuloplasty ring in combination with the preserved normal movements of the posterior annulus are going to determine how that zone of apposition comes together and how extensive it is. With a small ring, we've got our aligned edges. And as we make the ring smaller and smaller, we'll get more and more apposition. If you think of the knuckles as where the ring might be, we've got our alignment with the chordae and then the apposition with the ring. So that's where the annuloplasty come in. And it is helpful to be able to make small adjustments by having an adjustable annuloplasty ring. And probably 30% of the time we make some 2 to 3 millimeter shortening of 1 or more segments of the ring. We use this Stryker. We've got no financial interest whatsoever, but this is made by Stryker for laparoscopic surgery. We've stopped using the metal shaft here. We just use a little plastic sump tube, which makes a nice soft little way. And you only have to barely put the tip of this inside the ventricle. It's very important not to put this deep in the ventricle and spear the ventricle. So if we just sort of stepwise go through some of the steps in doing a big P2 leaflet, and I'm sure you can see here this massive P2 segment. We don't look at this and say it's too big. We don't think it's excessive. We think it's a great opportunity to get a really good zone of apposition. So here's our big P2. And when we have the more normal part, it's easy to see and mark that 50%. But on these leaflets, you simply stretch it up, come down here, and 100% of the time, we go to the 50% mark here and put our dots across the middle of this flap. So any of the larger areas that are somewhat featureless, they all get exactly the same from the edge to the annulus back to the middle to the 50% mark, and that's where we're going to mark our zone of apposition. We put our chordae into this, either up near where the other chordae is inserted or into the side of the papillary muscle. It's very important not to get these things twisted. These things can rub against each other and rub through, so we always have a left hand and a right hand thread. If we're putting our chordae up near the base of other native chordae, we don't want the native chordae rubbing these chordae. So you have to run the chordae up from the papillary muscle without interfering with any of the functioning chordae. Now, one of the things you'll see as you operate on more of these patients is sometimes you'll open up and you'll wonder exactly where are the papillary muscles. And this is a paper published a number of years ago that documented over 100 variants of papillary muscles, ranging from little bridges, single papillary muscles. You're looking for the anterolateral papillary muscle and it isn't there. There's just one big one, all the way to essentially chordae coming up from the muscle without any papillary muscle. So don't be alarmed if you don't see things at first sight. Just look around and you'll eventually be able to trace back the chordae from the edges of the leaflets and find something somewhere that you can hook some chordae into. as we come down and start using, we are using more and more chordae per segment. And so sometimes you'll use up what you can find on the tip, and you might have to bring a couple of chordae off the side of the papillary muscle. It's very important as you come down these papillary muscles to be aware that the attachment of the papillary muscle, which is a pretty meaty structure, to the wall of the left ventricle is by trabeculae. So the big solid muscle ends, and then it's attached by trabeculae. And Dr. Duran has suggested this gives this a shock absorbing like characteristic. So you don't want to put a stitch through here and it crows out one of these major trabecular attachments of the papillary muscles. This is just very important anatomical detail to be aware that when you look down there, if you look carefully, you'll see the main papillary muscle end, and then it breaks into these trabeculae. Now, what we've recommended, because the whole concept of this approach is that every single thing about the repair can be adjusted through all the testing as we put the components through one by one, the chordae, the annuloplasty ring. We can keep adjusting and keep moving things around until we get things the way we want them. And so we've got our number 5 Gore-Tex chordae coming up from the papillary muscle. We come up through the ventricular surface of the leaflet, and we swing around and make one turn and come out of the atrial surface. So that's our left-hand stitch. Right-hand stitch, we come up through the leaflet, up, around, and then from the ventricular surface up to the atrial surface. And this should be a 6 to 8 millimeter gap here. And then between that and the next one should be a 6 to 8 millimeter gap. So this has the dual purpose of spreading the load along the edge a little bit and supporting a little more of the edge. But very importantly for this technique, this gives us enough friction that we can grab these strings here and then slide the leaflet. So we can hold these strings in our hand and then grab the leaflet here with pickups and slide this down the chordae. And that way we can test with our pressurization, with our dots on the leaflet, and keep moving things around and until we get things exactly where we want, and then we tie down the chordae. So that's a very important step, and it's a little harder to slide it back, but if you support the chordae underneath here, it is possible to grab the leaflet and lift it back. The most common mistake made in my experience with use of chordaes is making them too tight. So when you start adjusting the chordae, you want to do your adjustment in increments of 1 to 2 millimeters, and just be very careful not to over tighten. For sure, you're going to feel a strong urge to tighten the chordae. You're not going to, when you first start doing this, you're not going to believe that the testing is accurate, and you're going to be tempted to tighten these up a little more, and that will then cause leaflet restriction and lead to a significant MR. And it's interesting, but on the anterior leaflet, the amount of adjustment needed, even though this anterior leaflet may look like a big mess, it often takes only a 2 or 3 millimeter adjustment on the anterior leaflet. In general, anterior leaflet chordal reduction is much, much less in need of adjustment. Sometimes just the position they're in, just from lifting the leaflet up and putting the chordae in, is all you need. So be very cautious adjusting the anterior leaflet, not to do any big over tightening. So here we are. We've had our chordae, which you remember we put in the papillary muscle. And obviously you want to put it in the part of the papillary muscle that's facing the part of the leaflet, like the P2 segments. You want to be coming off the posterior surface of the papillary muscles, and the anterior leaflet, you want to be on the anterior surface of the papillary muscle. So now we've got these chordae in and we've run them with their little loopings. We've now put the dots on. And as I say, with a big posterior leaflet, you want to go directly to the exact middle 50% mark to restore that 50%. And then over here, we'd be putting our dots at the 50% mark, which would be visible anatomically. And also the clefts can provide a guide. The dots should be about the level of the top of the clefts. And you can see here, here's a normal mitral leaflet, and you can see that here's the 90-degree transition. You can see which is more or less corresponds to the top of the cleft. And you can see here, we put the dots along that shoulder where that 90-degree transition comes. anterior leaflet, the zone to mark is a lot easier to see because we've got this very nice clear zone that's always very prominent, and the zone of apposition is almost always very roughened up. So it's much easier to put your dots here. Now, in regard to the anterior leaflet dots, once you've got them in position, you've got to remember that the testing we're doing initially, when you do a little bit of testing, you'll see the anterior leaflet dots seemingly to be a little high, but as the testing progresses and you get the anterior leaflet and root expanding and rolling in, the dots come down more. So you don't worry about your dots being in a slightly high position until the very end. And at that point, they should be pretty much coming down. And then this is one part of the simulation where the movement of the dots on the anterior leaflet is even more pronounced as the heart starts beating. So even if the dots is just still a shade high, that will come down as the heart starts beating. And again, the clear zone here makes it very nice to be able to see where to mark the dots. So here we are, that same picture we had of the posterior leaflet 50-50, anterior leaflet 70-30. And this is how the dots should look if you have perfect apposition. And if these dots are somewhere back up here, that means the chording needs to be tightened to bring them down here. If these dots are up back here, then obviously that needs to be pulled down. If the dots are separated from each other, that means our annulus is not small enough. So you're gonna have to make the annulus smaller to get the dots to come together. And again, suction irrigator, indispensable equipment in my opinion. This is just to show the effects, what we do while we're testing. We go through the whole valve, have a good look at it with the right angle and check for ruptured chordae, and then we actually inflate it. We always put these annular, 3 or 4 annular stay stitches in to allow us to prolapse the whole valve up and out for reasons of exposure. And in addition, we're then able to use these, we rotate these forward to simulate that 25% reduction in annular area. And so this is our testing. You can see those leaflets if you have the annulus pulled forward and the heart filled, that's actually, the leaflets do get that locking together under the pressure of the thing. So here we've done our testing, we've made our adjustments. This cord here needs to be shortened a bit to get this dot to come down here. So you're going across the whole thing, carefully adjusting each of these chordae individually, and this has been inflated. And we're now looking at the inflated valve with the annulus pulled forward. And we're now in a position to select the correct annuloplasty ring. And we simply get an annuloplasty ring sizer that fits this opening. We don't have to make any assumptions or stretch anything up or look at the size relative to a leaflet. We simply get the annular size here and put the sizer in that matches this annulus. Here is a little bit of footage from a robotic mitral valve, just showing how we adjust the chordae. We've got a posterior leaflet, we've got chordae in the free edge, and we're doing our initial adjustment, which you can just go ahead and sort of arbitrarily put a couple of millimeters on the chordae, and then you blow up, and you see the dots aren't coming in far enough on the posterior leaflet. Even with the posterior annulus pulled forward, the dots are still back here. So this means we've got to shorten the chordae to the posterior leaflet to bury those dots down further. So you'll see us grab the posterior chordae here. And once we've got the chordae grabbed, we now get down and grab the leaflet by the chordae and slide the leaflet down those chordae. You see how we're sliding it down? And then we do the same thing with the other chordae to line their dots up correctly. So you can see already the dots look better. And then when we reinflate, we're going to grab the posterior annulus and pull it forward. That's the 25% reduction. And now we're going to inflate. And as I say, you barely need to be in the ventricle to inflate. You don't want to poke that all the way into the ventricle. And see the dots right before it pushed up, you can see the dots were in a good position. This just illustrates you don't want to overinflate. You want to inflate up until the aorta is filled up and the leaflets are bulging, but you don't want to inflate to the point where the chordae will slide up the leaflets. And it's at this point with the posterior annulus pulled forward that we can get our sizer in, and we true size to the annulus that we have there. So you can see we're sizing to the actual circumference of what's right in front of us. There's no tricks or adjustments or any pushing or pulling on leaflets. We simply size the annulus we have in front of us. And we really recommend the use of an adjustable annuloplasty ring. Again, I helped develop this with St. Jude. I have zero financial interest in it, but we've used this in more than 1,500 patients. It's totally flexible, and we can individually adjust the P1, P2, or P2, P3. And this is actually, we really like those dots to be perfect, and this gives us an opportunity at the end. If the dots aren't matching up perfectly in some area, we can actually selectively tweak that part of the annulus to bring the dots together in that area. So I really commend this to you, and we do the adjustment about 20–30% of our cases, usually not very big, just 1 or 2 millimeters. But sometimes as you do your inflation, you get these little jets coming out, and just a 1 or 2 millimeter adjustment of the annulus eliminates the jets, so that when you unclamp, you have no MR whatsoever in almost all of these patients. Very important to be diligent about sizing the annuloplasty ring. As we've talked about, the normal contribution of the atrial contraction and the ventricular contraction to reduction in mitral annular area is about 25%. Each time we change the size of ring we're picking, that's about a 15% reduction as they get smaller. So if our normal change is 25% and we get 1 ring size off, we're making a 16% error in the area we'll ultimately accomplish, either too big or too small. So very important to size. And the number one place to make sure you're properly sizing, to retract the atrium a little bit and make sure you're looking out and seeing the commissural area. Sometimes it's easy to put the sizer in and the atrium will be obscuring the region of the commissure, and you can undersize. And as we mentioned, the place we want to get our suture line to end up here, here's the wall of the aorta, the aortic valve leaflet, the atrial myocardium. We don't want to be working down here as recommended by Dr. Carpentier, just on the edge of the muscle reflection, or the so-called mitral ring. We want to be right up here near the aortic valve. And I can assure you that if you get your needle, and always take your bite downwards, don't ever swing a needle up in this area, always be swinging your suture lines downwards. And you feel around in here, there'll be one area here that's thick and very resistant, and that's the area you want to pick up the sutures. And that will be some part of this transition between the aortic mitral continuity and the leaflet. But there's always some thickened area in here, and it's usually somewhere right up here. And on the echoes, you'll see we almost always see our ring sitting right up in this area. So that's the very important technical detail. And that's how we get this shape here. And in addition, when we're stitching the ring on in this area here, we're not trying to shorten this area in any shape or form. In fact, we're trying to leave this area slack. And so this is being designed to be a restraint when the outflow tract has been pushed up and backwards towards us. This area is going to come up and back towards us. And so we actually, in this area, we're taking big bites on the annulus and small bites on the ring. In this area, we do the exact opposite. We take small bites on the patient and then do big bites. And that's why you see these things bulging out a little bit. And that's how you sew in this 3-dimensional annulus shape here. That's a 3-dimensional thing going up over the top of the saddle shape. So we've got a ring that in this area is positioned in a saddle shape. And that's the suture line pretty much coming up like that. This is the Carpentier trigone to trigone ring, and it immobilizes all this area here. So here's some footage from the OR, and watch the aorta here. You can see the aorta blowing up and flattening, and you can see the effects of the expansion of the aortic root with the left coronary sinus and non-coronary sinus. So you can see all that expanding, and now if we run through the loop again, watch the annulus here. That's the anterior part of the annulus under the left coronary and non-coronary. See how it's being pushed upwards and backwards, and the anterior leaflet is being pushed towards the posterior leaflet, and both leaflets are diving down into the ventricle as they get mitral locking. So that's how we simulate our repair, and that's what we'd like it to look. This we often would prefer to see the dots in a little bit in sight, and we normally put 12 throws on our Gore-Tex stitches, and that makes about an 8 to 10 millimeter knot pile. And if we can just see the tips of those knot piles, then that means we've got a nice zone of apposition. If the knots are laying out here clearly, then that means you've got to shorten the chordie. So here we took that big posterior leaflet, very large, and here you can see the left ventricular outflow tract is wide open. It's wide open. There's the point of attachment. Now, this footage is from a patient who was done in the earlier part of our experience, where we were still trying to line up the bottom edge of the leaflets with each other. And this is before we realized that this was leaving some degree of prolapse, not of the zone of apposition, but of the body of the leaflet. And so this is when we went to the 50-50 line and decided not to worry about where the bottom edge of the leaflet was at all. So we have a big P2 leaflet now, we don't have any bulge, and we expect this leaflet to be lower at the edge here than the other leaflet, so that we're not aiming for leaflet edge position anymore, we're aiming for 50-50 distribution of the leaflet. And that's eliminated this appearance, which sometimes upsets the cardiologist. So if one were to go to meetings and read the literature, one would assume that the Carpentier technique has led to perfect repairs in all these big centers, and particularly Mayo and Cleveland Clinic. But recent papers have suggested that things are not at all well in these institutions. And this paper in 2016 from Suri, from the Mayo Clinic, showed that for anterior leaflet and bileaflet patients, there was a 2 to 2.5 excess failure rate. So they may be doing okay on simple P2s, but when it comes to the more difficult cases, the Carpentier repair technique has simply been delivering poor results in these institutions. So just a quick look at a big anterior leaflet. We do exactly the same steps, identical, except as I mentioned, generally and somewhat surprisingly, the amount of adjustment needed, the amount of shortening of the chordie is much less. Here you can see the needles going through here. This one is a completed one. The suture's already been brought up through the leaflet, back around and then out. Here we've done first throw, and now we're doing the second throw, up from behind and then out. Normally for this amount of area now, we would probably do 6 or 8 chordie. This is an earlier case, but we wouldn't leave a gap like that. Just a few millimeters here and then the next pair of chordie. So this would have been at least 6 chordie on this big leaflet. Now we go through all the same adjustments, everything identical, the annuloplasty ring, everything. You can see the annuloplasty ring here right up against the aorta. And again, huge anterior leaflet, but I draw your attention to the left ventricular outflow tract, which is hugely patent because of our attention to the management of the left ventricular outflow tract. And here you can see the chordie going down to the papillary muscles. So how does the appearance intraoperatively line up with our postoperative appearance? Well, here we are with our simulation. The aorta is enlarging, the left coronary, non-coronary filling up, and the annulus is being rotated forward and backwards towards the posterior leaflet, and the leaflets are going down and flattening. And here's our postoperative TEE. And you can see here, this is the aortic root. And as it, you can see it rotating flat. As it rotates flat, you get to see more of the underside of the aortic valve leaflets. And here's the anterior part of the annuloplasty ring. anterior leaflet, posterior leaflet. And you can clearly see that in systole, the aorta is rotating down, the root is expanding, the anterior part of the annulus is being pushed backwards, and attached to that is the anterior mitral leaflet, and that's being pushed backwards, widening the left ventricular outflow tract and bringing it into good apposition with the posterior leaflet. So these look to us to be almost identical to what we see during our intraoperative studies. Now, Barlow's disease has been an enigma for many. We're using the definition of Barlow's, which corresponds to Dr. Carponier's definition, which is universal wide, large leaflets. You can have a leaflet, and if you want to call it a Barlow's leaflet because it's very big, that's fine. But Barlow's mitral valve should be reserved for people with big annuluses, 48 to 50 millimeters, and all the segments very big leaflets. That's a true Barlow's valve. And some people have got into these leaflets and found they've had to put Cordy on every single thing and resect lots of things. It's very, very much simpler than that if you follow these concepts. This has all been summarized in a 5-page review I wrote. It was published in 2015 in the Journal of Thoracic and Cardiovascular. I think we've sent you a copy of it. This is the big thing about Barlow's. These leaflets here are so huge, they act like gigantic sails. So in systole, there's massive force exerted by these leaflets on the Cordy, which pull the papillary muscles up. So normally the papillary muscles and the annulus are meant to descend 1.5 centimeters towards the apex as the ventricle gets smaller. And that brings the leaflets down, being pulled by the Cordy. In Barlow's, there's so much stretching going on here, the leaflets often go up more than 1.5 centimeters. So the principle here is that simply getting these leaflets to lay back down into the ventricle where they're not presenting that huge cross-sectional area allows the papillary muscles to move down normally. And without touching any of the Cordy, you've automatically gained functionally a 1.5 centimeter increase of the movement of the leaflet down into the ventricle. So unless you have asymmetry, like one segment bigger than another segment, there's no need to touch the Cordy on symmetrical Barlow's. And there's a movie we made of symmetrical Barlow pointing this stuff out that you can have a look at. So what's going on is like this when we look at the dynamics. In systole, instead of the annulus and the leaflets moving down into the ventricle, they're moving up. And you can see how the papillary muscles are being forcibly pulled up 1.5 centimeters instead of pulled down. So effectively, this gives 3 centimeters accessibility of the leaflets to move upwards. And simply by laying these down, they come to a perfect alignment. They don't cause SAM. And it's a very simple thing to fix just by sticking to these principles. And here you can see a MRI, and here's the mitral annulus. You can see these huge leaflets in systole being pushed up into the atrium. And you can see these papillary muscles here being bodily pulled up towards the annulus instead of moving down. And simply by putting on an appropriate annuloplasty ring, which is most commonly 37 or 39 millimeter ring, the leaflets now are laying down in the ventricle. They're not exerting this tremendous force. The mitral annulus is moving down towards the apex, and these papillary muscles here are also moving down normally towards the apex. So that's the principle of the treatment of symmetrical Barlow's. And if you have some localized asymmetry, you want to correct that to match the rest of it. You don't want to try to correct the whole prolapse motion of that segment. You want to simply get the valve into a uniform matched up state, and then you can just do the simple adjustment with the annuloplasty. And here's a 3D echo of the big billowing leaflet pre-op here. And here's the post-op. You can see the substantially smaller annuloplasty, 37, 39 as opposed to 50. And here again, the rocking motion with the aortic root expansion, pushing forward the anterior annulus and displacing the anterior leaflet towards the posterior leaflet. Now, we've done a number of studies and we had the opportunity to work with a group in Chicago, Dr. Lang, who's a prominent echocardiographer in the United States, and we're able to repair his Carponier repairs up there with our non-resectional repairs down here. And what we found was that pre-op, the patients were similar. They both had annuluses that didn't move very much, but did get, here's the end diastole, mid systole, end systole, mid diastole, late filling, and end diastole. And we found that this big dilated annulus did get a little smaller in systole, and then started getting bigger at end systole in a normal manner. And then the annulus was at its largest in mid diastole, then got smaller again in systole. When you do our approach and you preserve all the normal motions, we see normal physiology of the annulus. At end diastole, it now goes into early to mid systole, and you get a 25% reduction in area. And then in diastole, we get a corresponding enlargement back to the preserved dimensions of the diastolic mitral annulus, which means that you don't get significant mitral stenosis. And then the cycle repeats with end diastole with our end diastolic 25% reduction in area. Carpentier ring, we have the mid-systolic area throughout the cardiac cycle without any change, which is exactly how it was designed to function. So we think this is very important to the patients, both in terms of allowing the use of unresected leaflets, because this means that there's more room around for the leaflets, and it also means that we don't get mitral stenosis. Now, in terms of the geometry, how have we done in terms of actually proving that the techniques we've used restore the leaflet dynamics? These are studies done at the University of Houston, analyzing 3D echo tracking. And we looked at our control group. This is the normal saddle, the intercommissural zone, posterior portion, organic mitral regurgitation, big dilated up, annulus, twice the normal area, anterior portion flattened, not reaching its full height. And here after the repair, you can see we weren't able to demonstrate any significant difference between our control group and our repaired patients. So I'm giving you the assurance that these techniques work based on third-party independent analyses of our data by mathematicians and scientists at the University of Houston. We are doing restorative physiological repairs. As far as the left ventricular outflow tract, here's a patient pre-surgery, and we've measured the diameter of the left ventricular outflow tract and the aortic mitral angle in systole. Here it was 109 degrees. Length here in diastole. And again, the aortic mitral angle, as we mentioned, is flatter in diastole, so it's 118 degrees. But you can see here in systole, the left ventricular outflow tract is supposed to get bigger. Here it's 15 millimeters, here it's 19 millimeters. Here post-op, after someone has been operated on using these techniques, systole 19 millimeters, aortic mitral angle 115. Dimension in diastole 16, so we've got a systolic enlargement of the left ventricular outflow tract, which is what you normally would want to see. And the aortic mitral angle is going from 118 degrees to 115 degrees, but not to 90 degrees. So this is a normal range of aortic mitral angle, and that helps us keep our patent left ventricular outflow tract, and it keeps the normal filling to the apex in diastole and to the aorta in systole. Again, we've talked about the strain levels, and I just wanted to show you some work we've done. And this was a report for the first time in the literature of a technique which actually lowers the postoperative strain levels of the leaflets to below that normally observed in normal patients. So these techniques do produce very low strain levels. And you can see here that in these diseased valves with dilated annuluses, we've got these concentrations of strain, as we mentioned, around the posterior annulus here and around the commissures. And postoperatively, we've got a much smaller diameter annulus, and we've primarily got the normally seen strain just around the commissures. Same thing here, a little bit of commissural strain, but very little strain anywhere else. So this was very exciting for us that this work has in fact shown that strain levels are significantly lowered. So we have now in Proof, waiting anxiously for publication, a study of 1,068 patients of pure myxomatous degeneration. The initial paper was offered with other pathologies, which had also had good results, but we were asked to restrict it to our pure degenerative work. And these patients were followed 15 to 20 years. And basically, they were derived from my personal experience of 2,700 mitral valve surgeries, of which 2,200 were repairs. But as I say, this was the subgroup that was requested by the editors. And this was a group of people operated on between 2000, which was the last year we ever did any leaflet resection, and 2020. And during that time frame, we analyzed the results of 405 mitral valve replacements to confirm that none of these people received, none of these replacements were done in the degenerative disease. There's a very big appendix on this paper that has a lot of information. So please, when you're reading the paper, be sure to go to the appendix. There's a very large amount of information there. So here's our repair rates by pathology. The myxomatous and degenerative patients have had 100% repairability for 20 years. We've averaged 4 chordae to the anterior leaflet and 5 to the posterior leaflet. I would have to say we've trended up on this. We're probably doing, by chordae, we mean each pair is 2 chordae. Each stitch you put in produces 2 chordae. So we're averaging probably 6 chordae to the anterior leaflet and 6 to 8 to the posterior leaflet. Our average ring size is about 33 millimeters. For the big 50 millimeter annuluses, we would typically be looking at 35, 37, 39 millimeter rings. The Barlow's people, 37, 39. We were very preoccupied with making sure we had big zones of apposition, and we were probably undersizing slightly some of our earlier annuloplasty rings. So we've definitely had a slight trend. If we've got a good 10 to 12 millimeters of apposition, we may go up one size. And with our more slack anterior suture line, incorporating more of the annuloplasty ring anteriorly than posteriorly, that's led us to often go up one size. So we probably could correct this data to say that our average size now is 33 to 35. But for the big people, and just as a general rule of thumb, if you're not sure what size to use to go up one size, you can always adjust it down with the strings. And just as a very rough rule of thumb, if you just simply can't get a good handle on what size to use, get your preoperative value and reduce that by about 10 to 12 millimeters. So if you've got a 50 millimeter measurement pre-op and you're having trouble just because everything's hard to see and it's out of view, you could choose a 37 or a 39 ring, and that would be pretty close. So just because of the way they're selected, we had 10% concurrent cab and 7% tricuspid. We've become more aggressive about tricuspid valve repair, and we're probably up to 10 to 15% on tricuspid valve repair. This technique is a fairly quick technique once you master it. This is from case 1 to 1068, but it's about an hour clamp time for an isolated repair. And overall, taking all the different types of bileaf and so on, it's 67 minutes. Now, if you preserve the normal physiology, you can make dramatic reductions in mitral area and still leave the same normal leaflets. With the Carpentier technique, if you make this degree of reduction in area, you're going to have to resect leaflet because you will inevitably get SAM. So the reason we can do this successfully and routinely and not get SAM is because we've preserved that dynamic behavior of the mitral valve. Like everyone else, we've had a pretty low mortality, isolated repair 1%, isolated posterior leaflet 0.9. And this is a number of people in their 80s. Now, very importantly, our average mitral valve gradient is 2. And this is done in a lab, which is a reference lab. We've got a very renowned reference lab. Everyone gets a postoperative echo, and this has been the gradient. And hospitals stay about 9 days. We don't believe in pushing people out too quickly. Now, SAM, as I mentioned, overall, we reporting chordal and leaflet SAM. We had 3.7%. Caudal SAM was 2% of that. And then any leaflet SAM of any degree, we had only 1.7%. We only had 18 patients. And Dr. Adams has advanced this concept of significant SAM, moderately severe MR. And he actually used a grade over 55. We had so few, we made it 45. And that's 0.4%. And as I say, that's for the total experience. And we have gone to a little more attention to slightly bigger rings. And I think that this amount of significant SAM has never been reported before. And I think there's just very little SAM around in our patients. And the important thing is that within a few months, all of these had resolved. So within a few months, we had 0 detectable SAM on echo in our patient group. So looking at the big stuff, 10 to 15 year follow-up, significant MR, freedom, 94%, 6% recurrent MR, reoperation, 4%, and freedom from prosthesis, because half of these reoperations, if you don't resect the leaflets initially, many of the recurrences can be repaired again. And so freedom from prosthesis is a little better than the reoperation rate. So we've been pleased with these results. This is, once you get a grip on it, you have to understand all this stuff we've been talking about in this lecture. That's been the big barrier. People simply haven't brought themselves to settle down and really familiarize themselves with these things you're trying to preserve. But the 100% repairability can only be done if you recruit and incorporate the natural processes which enhance the tendency of the leaflets to come together. You cannot demolish all of the normal mechanisms that brings leaflets together and try to substitute some arbitrary set of rules to make the leaflets then be pulled back together. You have to get a technique where you're going to augment, enhance, and restore the pre-existing normal things that have all of our own mitral leaflets coming together on a pretty regular basis. And we think that the durability has been very good. We've overcome, we think, the large problem of SAM. And you'll see that mitral stenosis is still a story that's unfolding as more and more studies are coming out using exercise studies, and also seeing the deleterious effects in terms of right ventricular function and the incidence of atrial fibrillation over the long term, not just the first year or 2 or 3, but over the 10 to 15 to 20 year time frame, these bigger gradients. And there's enough literature now, I think we can say that any gradient over 3 has the potential to be associated with late sequelae. Well, thank you. It's been great being able to talk about this. We could, if you'd like, have some question and answers now and then show a few surgical movies, maybe just give everyone a chance to have a bit of a break, or we can go on to the surgical movies, just whatever you would like to do.
Yeah, we can show the movies now
Okay.
and then have a question at the end.
All righty, very good. We'll go forward with that. Well, we're going to start off with a paper that shows all the details of the technique. This is about 20 minutes. Let me know if it's dragging and we can accelerate through it. But this shows out very important information about cannulation and how we get exposure. People often wonder how it is that we get such good exposure, but this tells us how to do that. So this is the first movie, and this is a posterior leaflet repair. And we've covered a lot of the steps there, and you'll see them all brought together here in this movie. And it's narrated, so I'm going to leave the narration on.
An important initial element in the American correction is complete mobilization of the superior vena cava circumferentially from all its pericardial attachments. The lateral and medial pericardial attachments are divided, and the vena cava is mobilized fully from the right pulmonary artery. This is an essential step in achieving adequate exposure. The pericardial reflection between the right pulmonary artery and the right atrium is completely mobilized, and it should be possible to place both fingers under the vena cava when mobilization is adequate. The inferior vena cava is also fully mobilized in a similar fashion. Bicaval cannulation with 24 French catheters with dynamic venous assist is utilized with retrograde cardioplegia. An interatrial incision is made, which is carried around under the superior and inferior vena cava. Only retrograde cardioplegia is used for valve surgeries. The incision is carried under the superior vena cava and under the inferior vena cava. These are also important steps to avoid tearing of the left atrium. Very good exposure is usually obtained by these maneuvers. The valve is prolapsed into the wound, and the first stay stitch of 2-O-proline is placed in the posterior medial fibrous trigone. Further stay stitches are placed in the posterior mitral annulus, again of 2-O-proline. Usually 2 or 3 stitches are used depending on the size of the annulus. These provide the capability of simulating the effects of the annuloplasty by retracting the posterior annulus forward after the leaflets have been stabilized in their correct position. In this case, 3 posterior annular sutures were used. It's very important as the stitches are put in that the surgeon get a sense that some solid tissue is being picked up by the suture. The posterior annulus is very variable in its structure and its extent. In some patients there's very little fibrous tissue in this area. The final stay stitch is placed in the anterolateral fibrous commissure. This is a very well defined structure overlaid by a dimple, and the surgeon should notice quite significant resistance to the needle at this point. Here we demonstrate the ability of these stay stitches to function as an annuloplasty simulator prolapsing the posterior annulus forward. An initial assessment is made, inflating the ventricle with saline, and it clearly demonstrates the side of the posterior leaflet prolapse in this patient. Usually 75 to 100 milliliters of cold saline are needed to produce adequate ventricular distension. Also notable in the upper portion of the picture is the ascending aorta distending with the saline as the ventricle is compressed. It is notable how much pressure the valve can retain. The right angle is used to evaluate the posterior leaflet prolapse. It's important that the right angle be used to bring the edge of the leaflet towards the midline. The anterior leaflet is evaluated to try and determine a plane to which the posterior leaflet will be adjusted. The right angle is very useful for this purpose, along with the saline. The chordae of the anterior leaflet in this patient are relatively normal. The edge of the leaflet is brought towards the midline of the orifice. It is important not to simply pull up on the leaflets, but rather to pull up and project the leaflets forward into the orifice, as is shown here. Retracting the anterior leaflet with a sucker facilitates exposure of the papillary muscle. The posterior medial and anterolateral papillary muscle are visible. The first set of cortex chordae being placed in the posterior medial papillary muscle close to the base, not near the normal attachment of the native chordae. a simple figure of 8 stitches placed in the muscle, being careful not to strangulate the muscle, but at the same time taking a reasonably deep bite. No pledges are needed. By placing the cordie down low on the papillary muscle, the evaluation of the length is made much easier, and the geometry of the repair is much stronger, because the cordie arrives directly up from the base of the papillary muscle, more or less at a right angle to the free edge of the leaflet. Here we can see that there is a lateral and a medial thread. The medial thread is placed first. It's placed in a rolling fashion, being passed through the free edge of the leaflet twice, right in the area of condensation of the cordie. The second one is placed in position, again being rolled towards the first one which was placed, so that the two free tails come to lie close to each other on the posterior leaflet. This is an important maneuver because it provides the friction that allows adjustment of the leaflet before the cordie are tied down. It also spreads the load. Here the anterolateral pair of cordie are being placed again with a figure of 8 near the base of the papillary muscle. Here the cordie are being brought through the free edge of the leaflet once again in a rolling fashion, an initial pass and then a second pass, again providing enough purchase on the leaflet to give friction as the leaflet height is adjusted and tested. Here the second suture of this pair is being placed. Notice the resistance of the needle going through. This is quite a dense fibrous area where the native cordie fused with the free edge of the leaflet. At this point, the length of the cordie, surprisingly, is often very close to what is needed. The final adjustment of the chordal length will be made after the leaflet is marked 5 to 10 millimeters from its free edge with dots with a marking pen. This corresponds to the area which is to be buried to allow apposition of overlapping tissue of the anterior and posterior leaflets, approximating the normal physiology of the mitral valve. This will be more readily seen on the anterior leaflet. It roughly corresponds to the rough area of the free edge of the leaflets. Once the dots are in place, the cordie can be adjusted by sliding the leaflet down the Gore-Tex. The rolling sutures through the edge allow this to maintain some frictional force and allow the ventricle now to be inflated with saline. The posterior annulus is an important part of the amount of overlap which is generated as the leaflets roll forward. By the posterior annulus, the edges tend to get buried more. The ventricle is now inflated with 75 to 100 milliliters of saline, and it is apparent that the adjustment of the cordie in this case is now satisfactory. At this point, the annulus is sized. There is no concern about the size of the anterior leaflet. We are simply sizing the circumference of the mitral annulus as it appears to us, with the ventricle inflated and the posterior annulus displaced forward to the point where the leaflet bury at the edges is what we want. The ventricle is now decompressed to allow us to work on it more easily. It is apparent how much overlap is buried down between the leaflets. We can now tie the cordie down firmly but without too much force to avoid inadvertently tightening the cordie. The most common error in the use of Gore-Tex cordie is producing an over-tight repair which produces restrictive mitral insufficiency. 10 throws of Gore-Tex are placed. This knot mass measures about 8 millimeters and is also a useful guide. The knot should completely disappear when the leaflets are opposed. The Gore-Tex is so slippery that even with 10 knots, the Gore-Tex will unravel, and so a locking stitch of 6-O-Proline is placed around the top of the knot to lock it down so that the knot cannot unravel. 6-O-Proline has proven very satisfactory for this purpose. Once this has been completed, the suture is trimmed. The other Gore-Tex is tied down in similar fashion, again aiming for a firm knot, but being very careful not to tighten the knot as the knot is seated. Even after 10 throws, it is possible to produce tightening of the Gore-Tex. Minor adjustments to the length can be achieved by placing a right angle under the free edge of the leaflet if necessary, if there has been some tightening, and stretching it up slightly. This allows the Gore-Tex to seat into the papillary muscle a little more and also tightens up the Gore-Tex knot. So if the leaflet appears to be a little restricted, it is still possible to retrieve the situation, but if there is excessive tightness, then the cording need to be removed and the procedure repeated. The suture is trimmed. And once again, before the annuloplasty ring is placed, the apposition is tested. Here it is apparent that there is excellent apposition of the leaflets. All of the dots are just disappearing and the Gore-Tex knots are not visible. With continued inflation, the ventricle and the mitral valve become very rigid, and clearly the valve is completely competent. The fact that the area is under significant pressure is apparent. The annuloplasty ring which was selected is a full ring. All myxomatous patients now receive full rings because of evidence of changes in the dimensions of the aortic mitral continuity. The two sutures in the fibrous bodies are placed around the ring, and the stitches are brought through the ring. In this way, the ring is stabilized. The suture line is begun at the anterolateral commissure. We have found from experience this is the easiest way to achieve suturing of the anterior part of the suture line, because it allows the annuloplasty ring to be used as a retractor. Here you can see the ring being pulled down, facilitating placement of the sutures. It is important to remember that the atrialis muscle is reflected down beyond the line of the annulus onto the anterior leaflet, and so care must be taken again to encounter proper resistance and suture the true annulus in this area. It is important not to incorporate the anterior leaflet itself into the suture line and thereby reduce the area of the anterior leaflet. 2-O-Proline again is the suture being used to attach the ring to the annulus. Being able to pull the mitral annulus downwards in this area, as we saw from cephalad to chordad, greatly facilitates attachment in this part of the operation. Continuous suture has been used by us for over 20 years in these repairs and has produced excellent results. We do recommend use of a continuous suture rather than an interrupted suture. Once the suture line reaches the posterior medial commissure, it is noticeable here that there's significant resistance to passage of the needle. This means that the needle is being placed through the correct portion of the posterior medial commissure, which is very dense and fibrous. At this point, the suture used on the anterior portion will be tied off to the suture already placed in the posterior medial portion of the commissure. The suture line is continued around, but is stopped before we reach the midline posteriorly to allow further adjustment after the lateral portion of the suture line has been placed. In this way, minor irregularities can be compensated for. The ring is stretched firmly to lay it out nicely, and the suture is tied down. In this particular case, the posterior medial suture was a little anterior and was removed and replaced. The second suture is now continued on around the posterior medial portion of the annulus. As the stay stitches are reached with the suture line, they are removed. At this point, the suturing is stopped before the midline posteriorly is reached and the lateral portion of the suture line is begun. The tip of the needle is used to ensure that the true annulus is being sutured, again taking account of the fact that the atrialis muscle may be partly reflected down onto the leaflet tissue from the wall of the left atrium. This portion of the suture line is continued around. This part of the suturing is also facilitated by the posterior stay stitches which were placed earlier and which are now removed as the suture line reaches them. This portion of the suture line is brought to the midline. At this point, the remaining stay stitch is removed and the other portion of the suture line is brought around. This maneuver allows small adjustments to be made by sliding the ring back and forth between the loops of the suture line posteriorly if some adjustment is needed. Although the ring is not adjustable, it is possible to move the ring within the continuous suture line before it is tightened, and this sometimes allows significant improvement in the layout of the ring. Here again, before the suture line is tied down, it is stretched to get rid of wrinkles. This completes the repair with the suture line being tied down. Before it is completely tied down, we recheck to make sure there are no residual areas that could benefit from adjustment of the ring. With 75 to 100 milliliters of saline in the ventricle and a pressure in the ventricle 30 to 40 millimeters, there is no leakage, demonstrating excellent competence in this patient. These leaflets are overlapping very well and the repair is completed.
So that's the basic technical details. There's been some minor changes. As I say, we favor the ring a lot more in terms of spacing on the anterior portion currently than we did when we made that movie. And of course, we didn't have our pressurized inflation at that point. But I think you can see the general outline of things. So we're going to go to the next movie. We've got two more movies, which are only about 5 to 8 minutes. So we'll get them underway here. So we'll have a look at a short movie on anterior leaflet repair.
The movie, The American Correction, describes important details of exposure and cannulation and should be reviewed prior to viewing this material. It is available at www.geraldlaurymd.com. This patient has severe myxomatous disease of the mitral valve with a flail A2 segment of the anterior leaflet. There is a large eccentric jet directed posteriorly of mitral regurgitation. The annulus is dilated to 52 millimeters, but left ventricular function is well preserved. The large flail A2 segment of the anterior leaflet can be seen here. 2 oproline stay stitches are placed in the annulus. This stitch is being placed in the right fibrous trigone, just anterior to the posteromedial commissure of the mitral valve. It will be used to facilitate exposure and help with ring attachment. The stay stitches are placed in the posterior mitral annulus. This one is being placed in the P2-3 region. The second stay stitch will be placed in the P1-2 region. These will be used to facilitate exposure and later to move the annulus forward to simulate the reduction in area which occurs during the cardiac cycle of the mitral annulus by about 25%. Another stitch is being placed in the left fibrous trigone. This will be the starting point for our annular ring attachment. An initial testing is done, inflating the ventricle to analyze the disposition of the leaflets. In this patient, while the leaflets are all redundant, only the A2 segment has a caudal problem requiring correction. A Yonkers plastic sucker tip is an ideal retractor to expose the papillary muscles. The posteromedial papillary muscle here is well seen, and a number 5 Gore-Tex suture is being passed through the papillary muscle to a depth of about 1/3 the diameter of the muscle, and in the lower portion of the papillary muscle towards its base. A figure of 8 suture is used, and no pledgets are needed. It is essential to keep track of the left hand and the right hand limb of this figure of 8 suture, so that it can be correctly oriented as it is being placed into the free edge of the valve. The posteromedial papillary muscle has 2 heads, and the anterolateral papillary muscle shown here is usually large with a single head and provides excellent areas for caudal placement. Again, the suture is passed to about 1/3 the depth of the papillary muscle in the lower portion of the papillary muscle below the native caudal attachment level. Figure of 8 suture. Once again, it is critical to maintain awareness of the left limb and the right limb of these sutures. The leaflet is prolapsed up into the atrium. The first stitch placed will be the left limb of the left suture pair coming off the anterolateral papillary muscle. This is passed through the lateral portion of the A2 segment with a rolling stitch through the free edge of the leaflet. The purpose of the rolling stitch is to add some friction to where the suture passes through the leaflet so the leaflet can be slid up and down, and then testing can be done without the leaflet migrating back up the suture. The next stitch will be the right limb of the left pair, and it will be rolled towards the left to join up with the left limb, so that when they're tied down there will not be much of a gap between them, which would produce buckling of the leaflet. The left-hand suture pair is now complete. Visual checking identifies the left and the right limb of the right-hand pair. The right-hand limb of the right-hand pair will now be inserted through the free edge of the medial portion of the A2 segment. The rolling stitch is used again to provide the friction necessary to hold the leaflet in place once it has been adjusted for testing. The left-hand limb of the right-hand pair coming up off the posterior medial papillary muscle will be the next suture inserted. It's passed through the free edge, being sure not to incorporate much leaflet into the suture line so that leaflet area is not reduced, and again it will be rolled towards the right so that it will meet up with the previously placed right hand stitch rolling towards the left. The redundant cord is trimmed off. At this point the leaflets are dried to make it easy to mark them with our marker pen. The upper edge of the rough zone is marked to define the zone of apposition that will be buried once the ventricle is inflated. The rough zone is less well developed on the posterior leaflet, so either the free edge of the posterior leaflet is marked about 1 centimeter above its margin, or if the rough zone can be identified, the rough zone is marked. These dots define between them and the ventricular cavity the amount of leaflet which will be in apposition, and the disposition of the dots also allows an estimate of the alignment of the leaflets, that is the free edges. An extra stay stitch is placed because it looked as though this area would prolapse back during testing if it was not supported by an additional stay stitch. The leaflet will be now slid down the chordie, and it's apparent that a certain amount of force is needed to do this because of the friction generated by the rolling stitch. Usually an initial adjustment of 2 to 3 millimeters is all that is needed. The posterior annular sutures are now drawn forward towards the root of the aorta, across to the left of the patient. Retractor is changed from the large retractor to a small retractor to allow the anterior annulus to be under no tension. Suction irrigators are employed at a rate of 4 liters a minute to inflate the ventricle to systolic pressure. As the annulus is displaced forward and the ventricle is inflated, you can see that dots are relatively symmetrical and define a zone of at least 1 centimeter of apposition of the leaflets. The dots look quite symmetrical, which suggests the free edges of the leaflets are also well aligned, producing good alignment. The annulus is sized while forward traction is maintained on the posterior annulus during left ventricular inflation. The chordae are now tied down using 10 throws. Only moderate snugness is used to avoid any sliding of the chordae down into the ventricle, producing excessive tightening of the chordae and a restrictive mitral regurgitation from the chordae. The 10 dots form a knot pile approximately 1 centimeter in length, and when the operation is completed, these knots should be buried in the line of the commissure, further defining the 1 centimeter minimum desirable line of apposition. To avoid unraveling, the knot pile is locked with a 6-O-Prolene locking stitch. The suture is trimmed, and the suture coming off the posteromedial papillary muscle is now tied down. 10 throws are placed with only moderate tension. The main locking effect of the knots will be maintained by the 6-O-Prolene. It is very important at this point to resist the urge to tighten down the leaflet a little further, because it is normal for the leaflet to be prolapsing up into the atrium in this slack state. However, once the annulus is made smaller and the ventricle is inflated, the leaflets will descend down into the ventricle. The 6-O-Prolene suture is placed. The suture is trimmed. The ring is seated and tied down. The suture passes from above downwards to avoid impinging on the aortic valve or aortic root. It is important that some of the muscle of the left atrial reflection onto the aortic mitral continuity be incorporated in the suture line, so the needle passes into the muscle and then out just where the muscle ends on the anterior leaflet. The junction between the aortic mitral continuity and the anterior leaflet is just above the visible line at which the left atrial muscle ends. On closer inspection, the previously placed right fibrous trigone stitch is a little far forward and is repositioned. The continuous suture technique is very effective in maintaining the full flexibility of the annuloplasty ring and is associated with a 0 incidence of annular dehiscence. It is by far the strongest way and the most mechanically stable way of attaching the ring to the annulus. Each time an interrupted horizontal mattress suture is tied down on an annuloplasty ring, that segment of the ring becomes rigid. So each suture used in this fashion produces a node of rigidity, converting our flexible ring to a semi-rigid ring. The suture line is continued across to meet the other stitch in the right fibrous trigone, and at this point the suture line is tied down to provide the ring attachment with 3 separate segments, anterior, left and right. Stretching of the ring with the fingers can smooth out any tendency for it to form wrinkles. The sutures are all tied together. And the previously used sutures divided. It's still possible at this point to adjust the spacing of the loops around the annuloplasty ring, and this is being done at the moment. Part of the appearance of the ring anteriorly is due to the fact that it is following upwards the shape of the saddle up into the left coronary, non-coronary portion of the aortic mitral continuity. The suture line is now continued posteriorly. Manipulation of the ring provides a good retractor in areas where exposure is limited. This is a particularly useful maneuver at the start of the suture line in the top left-hand corner. The use of an adjustable ring provides 2 forms of additional functionality. Firstly, if in doubt, a slightly larger ring can always be implanted, and the magnitude of the adjustment possible encompasses approximately 2 ring sizes. In other words, a 35mm ring can at a pinch be adjusted down to a 31mm ring. The second advantage is that the P2-3 segment is often quite large relative to the P1 segment, and sometimes asymmetrical adjustment may be needed to provide an optimal annuloplasty for the pathology encountered. This is particularly the case in myxomatous valves with large P2, P3 segments. The other circumstance under which this asymmetrical functionality is useful is in ischemic patients, where the P2-3 segment may be more maximally diminished than the P1 segment. If the ring appears satisfactory without adjustment, the green strings are simply divided close to the ring. The ring is manufactured to have ample strength without the strings being tied. the suture line is spaced out correctly, and then tension. The P1, P2 portion of the suture line is now performed. The suture in this case is passed under the ring and then used with the ring as a retractor to show the cul-de-sac up near the mitral commissure. In this way good exposure is obtained. The completeness of the annulus as a structure varies around the mitral annulus. In some areas the annulus is well developed as a fibrous band. In other areas it is a minimalistic structure. It is important to feel with the needle for some resistance and ensure that the thickest tissue in the area you're suturing is being sewn. The circumflex coronary artery is behind the suture line, but if normal size sutures are taken, it is not close to the annulus and is rarely damaged. The suture line can be completed between the two green strings, or it can be completed to one side of the strings, whatever is more convenient. The adjustability of the ring will be preserved either way. Further final testing is now done. At each stage of this procedure it is still possible to make adjustments before the final result of the repair is achieved. Saline is infused at 4 liters a minute until systemic pressure is reached. The annulus moves away from the surgeon and the leaflets dive into the ventricle and flatten out. The saddle shape of the annulus forward is quite marked. Postoperative echo shows excellent leaflet function with a wide open outflow tract and no SAM. The annular dimensions are excellent, and annular function on 3D echo reconstruction was normal, physiologically preserved. The saddle anteriorly on the left next to the A for aorta is well preserved. The valley between the commissures is also well preserved, and the moderate elevation of P2 is also preserved. The leaflets slope downwards into the ventricle obliquely and have a good line of apposition.
Okay, so we've got one more if you have time for it. This is about Barlow's. And this is only 6 minutes, so.
Barlow's disease of the mitral valve occurs in either a symmetrical form or an asymmetrical form with chordal elongation as described by Dr. Carpentier. In this patient, there's massive annular dilation to 55 millimeters, large prolapsing leaflets, elongated chordae, and a large amount of central mitral regurgitation. Left ventricular function is reasonably well preserved. The massively enlarged prolapsing leaflets with increased extensibility and elasticity are shown here. Leaflet area is more than double normal. All segments of the leaflets are involved, and the annulus is dilated to 55 millimeters. However, the chordal abnormalities are symmetrical, and no alignment correction will be necessary in this patient. The first step is the placement of annular stay stitches. This stitch is being placed in the right fibrous trigone, identifiable by a small depression in the endocardium over this area, just anterior to the posterior medial commissure. When the needle is passed through the tissue, strong resistance should be encountered if the needle is in the correct position. The next stay is placed in the P2, P3 portion of the posterior annulus, and will serve both for exposure and for subsequent manipulation of the mitral annulus during sizing of the correct mitral annuloplasty ring. Another stitch is placed in the P1, P2 area of the posterior annulus. Sometimes 3 stitches will be required to produce adequate exposure of the posterior annulus. This stitch is being placed in the left fibrous trigone, which is slightly anterior to the anterolateral mitral commissure. Again, it is usually identifiable by a small pit. Initial inflation of the leaflets demonstrates symmetrical prolapse, and with the annulus not manipulated forward, the leaflets prolapse up into the left atrium. The desired line of apposition is now selected. Where visible, the upper edge of the zone of the rough area is marked. If not, approximately 1 centimeter is marked, or if the transition zone where the edge passes down 90 degrees to the main body of the leaflet is visible, this is marked. Usually the rough zone is visible and is most commonly marked. Inflation of the ventricle now produces prolapse with the dots moving away from each other. When the posterior annulus is brought forward towards the aortic root to simulate the 25% reduction in annular dimensions during end diastole and early cardiac systole, the leaflets roll into the inflated ventricle and the correct zone of apposition is formed. At this point, the entire annulus is sized, usually for a 33 or a 35 millimeter ring in these patients. The annuloplasty ring is secured to the mitral annulus with a running 2O-proline stitch. We have found that the running suture technique is very durable. We have had no annular dehiscences in over 1,000 patients. It preserves full flexibility by not producing any nodes of rigidity where sutures are tied down onto the ring. It is important that the sutures be passed through the atrial muscle over the top of the aortic mitral continuity to ensure the correct part of the mitral annulus is secured by the suture. The suture should be passed from above downwards to avoid the aortic valve, and exposure of this area is facilitated by use of the ring itself as a retractor to position the annulus for suture insertion. Now that the ring has been secured, when the ventricle is inflated, the leaflets initially prolapse upwards slightly, but as inflation continues, the leaflets move down into the ventricle, and the the leaflets move down into the ventricle, and the saddle steepens anteriorly, reflecting inflation of the aortic root and the ventricle. SAM is not produced by this technique when the annulus is correctly sized by a dynamic method. Here we can see the preoperative and the postoperative pictures. The left ventricular outflow tract is widely patent with no SAM, and the 33 millimeter annuloplasty ring is in position. There is no mitral regurgitation, and there is no prolapse of the mitral leaflets.
Well, that's the three videos that we chose to show today. You have some other material available, and certainly be good to look through some of that. I'd be glad to have any discussion or questions now, Luawi, just whatever you would like to do.
Thank you, Dr. Lowry, for this excellent and thorough presentation. Actually, you answered all my questions, but just I have one. How reproducible this technique, especially for like a junior surgeon to get this excellent result?
I would have to say, after having many 2-day seminars and teaching this technique, the number one problem is people understanding this is a total, complete break with all previous techniques. Over the years, we've had these groups of 30 people come to Houston for a 1.5-day course. And afterwards, I've encouraged them to call me if they have problems. And the calls I get are things like, I put the Cordy in, I did all the adjusting, and then I put on a rigid Carpentier ring and I got SAM. What do you think I did wrong? Well, obviously, one of the themes here is that you absolutely cannot use a rigid ring with this technique. So really the number one barrier, just to give an anecdote, when I came to Houston, I worked with Dr. DeBakey, who was at that time one of the foremost heart surgeons in the world with massive experience. And day after day after day, I helped him do things like carotids and other things and learn his technique. And then instead of adapting his techniques and using them, I tried to modify them. And after a while, I suddenly realized, why don't I do what he's teaching me? And I did that, and that's to this day, I've used his techniques. So the big barrier here is the Carpentier technique has been around such a long time. It's so widely used and discussed. It's been extensively modified, but this is a total break. And the two things the younger surgeons need to do is, number one, really become interested in how the mitral valve works. And we've given a lot of references in the papers I've sent to you. But the number one barrier is an intellectual barrier arising out of the fact that everyone has literally grown up being taught the Carpentier technique and this emphasis on leaflet height and leaflet size and excessive leaflets and these erroneous explanations of why we get SAM. And so you have to become a student of how the mitral valve works. And then I would say that at the moment, my best advice would be to do exactly, precisely, and without any deviation, what we've recommended in these movies, because this is the same. Obviously, there have been some minor adjustments you saw over the course of when these videos was made, but these maneuvers are exactly what we do on every case. We put the stay stitches in, we examine the valve, we make sure we've corrected all the prolapsing, ruptured chordae and asymmetrical things with the chordae. We adjust the chordae, we have our dots, we use the pressure inflation. We change from a big retractor to a little retractor so that the atrium can move around properly. It's attention to detail doing exactly right. And I think that there's no reason you can't get these very good results very rapidly. I think starting out, you could probably expect a 90% repair rate. For reasons of time, I did not show anything about A3P3 area, for example. Generally, the problem there is that normally there aren't many chordae in that area. So typically what we do is we may put one pair of chordae in A3 or P3 just to get us to within 7 or 8 millimeters of the annulus, and then we do a K annuloplasty and plicate out the last little bit of A3P3, but there's a limit to how much of the anterior leaflet you can incorporate. If you're getting up more than 7 or 8 millimeters of the annulus of the anterior leaflet in that area, then the anterior leaflet motion will be affected. So you have to try to stabilize a little bit of the A3P3 with chordae and then do the last little bit near the commissure by imbricating with a K annuloplasty. We haven't discussed the mitral annular calcification. We do have a material on that, which I think I might have sent you, or at least given you a reference to. So all these other details, but the hardcore mainstream anterior, posterior, and Barlow's valves, I think any young surgeon who has taken the time to understand and learn what to do should be able to start doing it immediately.
Okay, thank you, Dr. Anyone from the audience have a question for Dr. Lowry?
If you allow me, Dr. Lowry. This is Faisal. I'm a final year in my training. First, I would like to thank you. It's really a privilege to hear from such a pioneer in this field and sharing this experience with us. My question for Dr. Lowry, in case of presence of aortic prosthesis,
Yes.
would this technique change, especially that the anterior leaflet suture site, especially that aortomitral coupling is distorted a little bit?
Yes, that's a good question. The first potential problem is that it may be a little harder to expose the anterior area, so you want to be sure that those cavea are really well mobilized. I think you could see on the first movie how we pull up and the cavea are going up at about a 45-degree angle. So you are going to probably have some little bit more difficulty, but if you put the stay stitches in and just work your way up, it's usually possible to get good exposure. The aortic valve has less of an impact than you might think because the actual expansion of the aortic root is subannular. It's the subannular aortic root that expands. It's the part of the sinuses, it's part of the aortic root that's below the level of the aortic annulus. That's the main part that expands. The stitching in one sense is not a problem because it doesn't matter how deep you go there. You're not going to worry about picking anything up, so you can go up fairly high with that. We've done a number of redos where we've come back and done a mitral repair after an aortic replacement. It's really not been an issue. I would still try to get that elevation and upward line on the anterior annulus by taking the bigger bites in the tissue and the smaller bites on the ring. That wasn't well illustrated in those movies. We really need to make an updated movie, but it is important to give more ring to the anterior portion. But I wouldn't have any concern. I'd apply the same principles. And because the exposure is a little more difficult, definitely remember to keep your assistant holding the anterior suture line tight and use that ring as a retractor. And you can pull down pretty firmly on that ring while you're placing the next suture. And that helps a lot. But I think exposure is probably the main impact of having an aortic prosthesis. Functionally, we've not seen any difference in how the echo looks in terms of the mobility of those areas. We still see that same anterior movement of the anterior mitral annulus, even with the presence of a prosthesis. And I appreciate your kind remarks, Faisal. Thank you.
Okay, any other question? So Dr. Lowry, how did you manage these few numbers of SAM that you had in your series?
Well, I really can attribute this to the fact that we at Methodist and at Baylor, we've always had a very strong presence in the field of imaging, cardiac imaging. We've had a leading presence. We were early introducers of transesophageal echo, and then we were early adapters of intraoperative transesophageal echo. And we've always had a strong academic interest in that. So I've been a student of the motion of the mitral annulus for many years. And of course, a lot of these things about the motion of the mitral annulus were learned in the early days of cardiac catheterization. For example, the changes in the shape and size of the mitral annulus were documented in the early 80s from studies done by HeartCath. So the onset of transesophageal echo was a revelation to us, and we've had a much clearer understanding of what the left ventricular outflow tract is, how the left ventricular outflow tract functions, how the position and dimensions of the left ventricular outflow tract are influenced by the aortic mitral angle. That picture I showed you with the three panels with the normal left ventricular outflow tract, with the normal aortic mitral angle, and then with the prosthesis, and then with the ring, actually came from Dr. Carpentier's own cardiologist. That's where that was derived from. So this acute angulation of the aortic mitral angle has a big impact. There's a lot of work being done on the vortex flow. And I think the way we've gotten rid of SAM as a problem has been to understand that it's not related to leaflet size. This is the big barrier to getting rid of it, because that is not the cause of it. The cause of it is failure to recognize that you're distorting the left ventricular outflow tract. Some people don't really even understand that the anterior leaflet is the posterior wall of the left ventricular outflow tract. So it's not a matter of the anterior leaflet floating in a left ventricular outflow tract and getting pushed from one part of the left ventricular outflow tract to the other. That is the left ventricular outflow tract. And you really should be thinking about the position of the anterior leaflet causing narrowing of the left ventricular outflow tract. So the SAM comes because the posterior wall of the left ventricular outflow tract gets too close to the septum. And that can happen because of a bad aortic mitral angle. As you saw, the vortex flow doesn't get that big vortex behind the anterior leaflet. It pushes towards the posterior leaflet and helps correct closure. And it directs the jet of blood straight at the anterior leaflet and pushes it into the septum. And then, of course, if you resect leaflet, if you go to the literature on mitral stenosis, you'll find that the number one thing that causes mitral stenosis, obviously, is a small ring. But the number one cause of a small ring being needed is leaflet having been resected. So if you leave the leaflets big, that also includes leaving a big normal anterior leaflet, which means you've got a big normal dimension to the left ventricular outflow tract. And so you just have to preserve all these things. You don't have to be super clever. You just have to avoid, it's like a lot of heart surgery, to get good results, you just have to avoid damaging things. And that's why I've spent so much time with you this morning going over all these different mechanisms that which we have identified from the literature and our own studies over the years. The fact that the mitral valves we repair now are functioning with completely normal strain levels, and the studies on the dimensions and shape of the mitral annulus all confirm restoration to normal. And the MRI studies we showed with the dimensions and the aortic mitral angles pre and post-operatively all show that we've been rewarded for preserving normal mitral function by getting rid of SAM. And I think you saw that Barlow's patient we presented where we put a 33 millimeter ring. Well, now we would have put a 37 or a 39 millimeter ring. And 1/2 of the SAM people we got were actually Barlow's. So I think the next 10 years, the SAM will be essentially very close to zero. But it's a lot of different details. And as surgeons, there are not many operations. You don't need to have a detailed understanding of the physiology of how aortic valve leaflets open and close and what happens to the aortic root and so on and so forth to resect an aortic valve and put it in a new prosthesis. And you don't have to know a whole lot about the function of the mitral valve to put in a mitral valve prosthesis. But I think to get successful mitral valve surgeries, you have to know and understand a lot of the details about the anatomy and physiology of the mitral valve. And I've tried to summarize this morning the things that we think are important to know about that to help you understand why we've recommended these maneuvers. And all these different times when we're pushing here and pulling there and inflating and marking the things are all based on those earlier parts of this talk. So I think it's just an attention to detail. And having had probably 200 people come through our courses, I think half of them have gone back home and adapted Cordy, but they still do not understand. I mean, there's still a complete misunderstanding of what the phrase respect or resect means. Dr. Perrier, who's given a lot of attention for making this phrase respect or resect, actually used Cordy to tightly make the posterior leaflet stretch down like a rigid structure to the posterior papillary muscle. So instead of doing a quadratic resection, he substituted a set of Cordy that pulled the posterior leaflet down, totally immobilizing it, just like a Carpentier technique. So his point was that it took away a lot of decision-making about how much leaflet to resect and so on. But in no way was he using Cordy to restore or preserve physiological function. So we've still got in the literature endless discussion about resect or respect. And I think many people using that phrase simply don't know that they're using a phrase that's describing an operation that's destructive to the physiology, just like we see the immobilized posterior leaflets with the Carpentier technique. So I think if you want to take on this kind of repair, which is very rewarding, because once you get the hang of it, it's actually much simpler, quicker, and easier. It's 100% eliminated having to go back on the pump and redo the repair or make adjustments. All of that's done with the inflation. And we've never had to take someone back to the OR perioperatively after going up to the ICU because of problems. So it just makes everything a lot easier, a lot nicer. And it's so nice to just unclamp and find no SAM. You can see not only is there no SAM, but we're not even close to SAM. You saw those anterior leaflets and balas with those very big left ventricular outflow tracts, which in all our patients get bigger during systole. There's no hint of SAM in almost all our patients. But it does require a commitment. And I think it does require some degree of finding someone who's actually interested and has a real driving intellectual interest in this topic, who's willing to take it on. I'm not sure that this is ever going to become something that just any surgeon who wants to do 2 or 3 mitral valve repair a year is going to master. I do think it's easily mastered, but it just requires someone to do a lot of reading, read the papers, and get an understanding of what's needed, because the physiology is complex, but I truly, we spent 5 years converting this from a technique that I was able to do. We analyzed every component of exactly why I was doing what I was doing and brought it down to a standardized approach. And then after 5 years of that process, we then went public with it and started presenting the data. So I do believe it is a truly reproducible technique, but only for someone who's going to have the commitment to take it on and watch closely every detail of what they're doing.
Thank you, Dr. Lowry. So I believe no more question from the audience. So by this, we have to end our session for today. Again, I would like to thank you for accepting our invitation and spending this time with us. And
Well,
hopefully
thank you.
we'll see you. Thank you.
It's been a privilege to meet with you, and I'm very proud to have the opportunity to help perpetuate the excellence that began back in the 70s, as you described. We were very proud of our association, and we have nothing but very happy memories of our involvement with King Faisal Hospital and cardiac surgery in Saudi Arabia. So I've really enjoyed the opportunity to speak with you this morning. Thank you.
Thank you very much. And hopefully we'll see you soon in Riyadh, inshallah.
That would be very nice. Thank you so much, and every best wish to you. Thank you.
Thank you very much. So by this, we'll conclude our session for today. Thank you for attending, and see you next week.